Hi, this is Dr. Joshua Cooper, and this presentation is on the diagnosis of SVT in the EP lab, usually for the purpose of catheter ablation. Before I begin on this SVT video, I had a few opening thoughts I wanted to share. First of all, a lot of the concepts that I'll review in this SVT video are based on a foundation that was established in some other videos that I've already posted, including the Introduction to Electrograms and the EP lab video, the one on entrainment and the post-pacing interval, and the one on atrial flutter. There will be a lot of overlap because I will review how to interpret electrograms and where catheters are placed, but if you find yourself not understanding a particular basic concept that I don't explain in enough detail here, you might find your answers in one of these other videos, and then you can come back to this SVT video to continue with that additional knowledge. I'm not going to cover every single SVT maneuver out there. There are so many, but I'm going to cover the very basic ones and the ones that are the most compelling and strongest that will get you through most of the cases that you will encounter. But recognize that there certainly are other SVT maneuvers, including those that have not even yet been described, that can sometimes be helpful to supplement the ones we will review. Also, there are exceptions to the rules that I will be talking about in this video. So rules I put in quotation marks because every rule has exceptions, especially when we're talking about unusual anatomy or unusual accessory pathways where some of the standard rules and observations that we'll see in most SVT cases may not quite apply. That said, the rules that I'm going to review are going to be true for the vast majority of cases that you'll encounter. There also will be details in the electrograms and the images that I'll show that I may not discuss. In fact, when I go back over electrograms myself, I often notice things in a subsequent review that I didn't see or notice the first time. If you notice something that I don't comment on that you think is relevant, certainly ask me in the comments or review these images with somebody who might be able to help you interpret something that I failed to explain. Again, this presentation will get you through the vast majority of SVT cases that you'll encounter, although perhaps not every single one. There are always complex cases where some of the rules are broken, or there are conflicting maneuvers that you'll do, giving you different answers. And so if you go through SVT cases in a very methodical way, do all the maneuvers, you should be able to get an answer using the tools that we'll discuss in this presentation. There's a lot of information, as I said, so you can always pause this video to process the information at your own pace. Some of the things I'm going to discuss may feel like they're going too quickly, and so I very much encourage you to pause the video and process what I've said, or even go back and review a particular slide or segment so that you can understand it in detail before proceeding. I'm so excited that you found this video and that hopefully you find it helpful. Let's do this. There are multiple mechanisms of SVT, of narrow complex tachycardia, or aberrantly conducted tachycardia. And most of these are easily distinguishable on the surface EKG or the clinical context. For example, when we're talking about sinus tachycardia, usually we have a more gradual onset and gradual resolution. The P wave has a very characteristic morphology because it is coming from the sinus node, and sinus tachycardia usually isn't a challenge to distinguish from other mechanisms, especially when you consider the clinical context. Atrial flutter usually has more than one atrial event for each QRS, and there's again a characteristic P wave morphology or flutter wave morphology that you'll see. So usually atrial flutter is relatively easy to distinguish. Atrial fibrillation is perhaps one of the easiest SVT mechanisms to distinguish from all of the others because the atrial activity is chaotic and irregular, and consequently so too is the ventricular response. If you see variable RR intervals, usually that signifies that all of the above SVT mechanisms are not likely what is going on. Multifocal atrial tachycardia is an unusual diagnosis that usually does not require any specific treatment, often seen in the ICU setting in a patient who is extremely sick, particularly with lung disease. And again, the treatment is usually to treat the underlying severe medical condition and not any specific treatment for that particular rhythm. The last one, junctional tachycardia, is often distinguished from the others because it usually starts with a narrow QRS rather than with an atrial event, and it is not that common as well. And there are maneuvers that can distinguish junctional tachycardia from some of the others. But the main three SVT mechanisms that can be the most challenging to distinguish from each other are AV node reentry, AV reciprocating tachycardia with an accessory pathway, and atrial tachycardia. In the AV NRT case, you need to have two components of the AV node, dual AV node physiology, for this reentry circuit to occur. In AV-RT, you need to have an accessory pathway that connects atrial and ventricular tissue in a way other than through the AV node. And in atrial tachycardia, you don't have any specific anatomic requirements, such as the above two, but instead you have a focal spot or sometimes a very small circuit in atrial tissue that conducts downward and creates a tachycardia from that atrial-only mechanism. Let's just review some of the visuals so that we're starting with the right images in our mind as we think about these three diagnoses that we need to distinguish from one another in the EP lab. AV node reentry, again, involves two components of the AV node and is a little short circuit that goes down one part of the AV node and back up the other. The second mechanism to distinguish is AV-RT, or atrioventricular reciprocating tachycardia. This circuit goes down the AV node, down the His-Purkinje system, across ventricular tissue, and up an accessory pathway, which is why it is usually also referred to as ORT, or orthodromic reciprocating tachycardia. Orthodromic referring to the fact that the wavefront is going in the forward direction down the AV node, down the His bundle and Purkinje system. Occasionally, the circuit can go in the opposite direction, down the accessory pathway and up the AV node, but that is very uncommon. That would be called antidromic reciprocating tachycardia. But again, the vast majority of times when a patient has a short circuit related to an accessory pathway, it is in this direction of AV-RT. And lastly, in an atrial tachycardia, as I stated, there's no specific anatomic abnormality, but instead you have a firing spot in the left atrium somewhere or in the right atrium somewhere, and this spot is conducting in a one-to-one fashion, often from atrium to ventricle, and needs to be distinguished from the other two mechanisms in order to treat it successfully with catheter ablation or other means. So the first question when we get to the EP lab to diagnose a supraventricular tachycardia is to ask the question whether there is abnormal anatomy present or how is this heart wired. And the very first two questions that you're going to ask when you get into the EP lab, when you're in sinus rhythm and you put catheters up and you start your EP study, are number one, is there an accessory pathway present, which of course is necessary for the AV-RT mechanism of tachycardia, and also whether or not this pathway has forward conducting or backward conducting or both properties, and we'll review how to ask and answer those questions. The second question that we ask is whether there is evidence of dual AV node physiology, which of course is absolutely necessary for AV node reentry to occur. And sometimes you have a patient who has both an accessory pathway present and dual AV node physiology. This type of patient could actually have two different mechanisms of SVT, or they may have one mechanism of AV-RT that requires the presence of a slow part of the AV node in order for that short circuit to continue and perpetuate to the point of causing SVT. As we start the EP study and figure out how this heart is wired, it is so important to understand how the normal heart works, including anatomy and electrical properties of normal AV conduction. And that centers, of course, upon the AV node and how it is normally positioned and how it operates. The AV node is located right in the center of the heart where the atrial septum meets the ventricular septum, right in the center, and that is critical for so many of the maneuvers and understandings that we have in the EP lab. Some people, in addition to having the AV node, which sits right above the coronary sinus ostium, some people have a right inferior extension that travels down in front of that coronary sinus ostium, and some people have a leftward extension that extends kind of along the coronary sinus a little bit ways into the left atrium, but the main part of the AV node sits right in the center, and we can talk about these variants where you have a little bit of an extension one way or the other and the implications on the EP study. In addition, it's important to recognize that the AV node is the slowest conducting part of the heart. Atrial tissue conducts relatively rapidly, ventricular tissue as well. The His-Purkinje system is lightning fast, much faster than any other part of the heart, but the AV node is the opposite. It has very slow conduction, and not only does it conduct slowly, but if you hit it a little faster with a premature atrial beat, for example, then it conducts even slower. That property is known as decremental conduction. That is the property of the AV node, that the faster you hit it with a signal, the slower the conduction velocity within AV node tissue. That is another critical piece of information to understand about how the AV node works when you start to ask yourself whether this patient has an accessory pathway or not, and whether they have an AV node that is functioning in the normal way. As we start to talk about the EP study, we must first talk about programmed electrical stimulation, which is the very systematic way that we look at the electrical properties of cardiac tissue, including atrial muscle, ventricular muscle, the AV node, the His-Purkinje system, and an accessory pathway if it is present. And the reason we need a standardized systematic way is because all of these tissues can behave electrically slightly differently depending on the heart rate. And so if you rely on the patient's underlying sinus rate, that can vary from one point to another during an EP study, which can alter the electrical properties of these tissues. So if we want to compare apples to apples at different points in time, we need to have exactly the same heart rate to start with the same electrical properties of the various tissues. And the way we do that is to pace with a certain number of beats, often 8 beats. These paced beats are known as S1, S for stimulus, and we often will start by creating a standardized environment at 100 beats per minute, which is 600 milliseconds, and we pace 8 beats in a row, and that creates a very uniform way to compare apples to apples at different times in an EP study. And only after these beats are delivered can you then deliver a test pulse, a challenge stimulus known as an S2, that second interval stimulus, which would be the 9th beat, and that can be delivered at a shorter interval than the S1 beats were delivered. And you can then alter that S2 beat after delivering the exact same 8 S1 pulses. So for example, shortening that S2 to 390 milliseconds. And you can repeat your standardized 8 beats and then test pulse at 380 milliseconds. And you can do the same thing and test at 370 milliseconds. And what you can do over time is to look and compare each S2 test pulse in terms of the conduction times across cardiac tissue from A to V, from V to A. You can look at refractory periods of different cardiac tissues. That means how early can you get before you reach refractoriness when the tissue is no longer excitable. And you can also use this S1, S2 systematic pacing maneuver to initiate arrhythmias. Reentry circuits are often able to be induced by putting in an early beat in the atrium or the ventricle in a very precise timing, and that can be done with this S1, S2 formula. Now, of course, we can pace atrial tissue, in which case these stimuli are known as A1 and A2. You can pace ventricular tissue, in which case they're known as V1 and V2. You can deliver more than one extra stimulus. You can deliver an S2 and an S3, in this case in the atrium, an A2 and an A3. You can deliver a third extra stimulus known as an S4 or an A4 if you're in the atrium. We often don't need to deliver a 5th or a 6th pulse because usually you can get all the information you need from doing S1, S2, S3 and S4 at times, and that should give you all the information you need. So let's start by asking question number 1, which is whether or not there is a forward conducting accessory pathway present. To answer the question of whether an accessory pathway is present in the forward direction, we need to first review how signals normally get from the atria to the ventricles in the normal way. The sinus node fires, it sends wavefronts across the right and then the left atrium, and the wavefront reaches the AV node. The signal then travels through this very slowest conducting tissue of the heart, the AV node, and then it reaches at its other end the fastest conducting tissue in the heart, the His bundle, the bundle branches, and the Purkinje fibers. And this His-Purkinje tree rapidly gets signals everywhere at once in ventricular tissue to create a narrow QRS, synchronous electrical activation where everything gets stimulated all at once, and thereby a mechanical synchronous contraction of the ventricles. In a standard EP study, we will place a His bundle catheter that is usually a 4-electrode catheter at the top central part of the tricuspid valve right near the His bundle. And because this catheter has a field of view that encompasses atrial tissue nearby, ventricular tissue nearby, and of course the His bundle itself, we're going to get 3 deflections in the distal pair, the middle pair, and the proximal pair of electrodes in this His bundle catheter. You see an atrial electrogram reflecting local atrial tissue, usually largest in the proximal pair. We can see this sharp His bundle deflection right in between the P wave and the QRS on the surface EKG, and that of course reflects a signal traveling down the His bundle. And we'll see a very large ventricular electrogram from local ventricular tissue that is often in the field of view of all 3 pairs because it is a lot of mass creating a large signal, and it is seen by all 3 pairs. As we take a measurement, the critical measurement of looking at signals getting from atria through this His-Purkinje tree to the ventricles, we take a look at the timing of where the signal goes through the His bundle itself. That's this His deflection here, this electrogram. And then we look at the time that the ventricles are initially activated. That is the fastest Purkinje fibers, the shortest Purkinje fibers that reach the ventricular muscle first to generate the very beginning of the QRS. And if we are to measure this time, we measure it from the beginning of the His bundle deflection to the very beginning of the QRS, the first Purkinje fiber to reach the ventricles. And that is measured as so on your intracardiac recordings. Here is this yellow line showing the beginning of the His bundle deflection, this blue line showing the beginning of the QRS on the surface ECG, and the interval between them, the HV interval, the His to ventricle interval, is very standard in most patients. It's between 40 and 60 milliseconds or so, and it is not under the influence of catecholamines or the vagus nerve, and it is a very stable, predictable number from patient to patient and at all times during an EP study in the very same patient. That HV interval being normal suggests normal conduction down the His-Purkinje network. Now the question comes up, how does that HV interval change when you have a different way to get down from the atrium to the ventricle with an accessory pathway? And here's how this would work. If you have a sinus beat, an atrial beat, it will reach both the AV node and an accessory pathway, but because the accessory pathway tissue is rapidly conducting typically, then the AV node, even while it may get the signal first, conducts very slowly, and that gives an opportunity for a signal to go down the accessory pathway and start to activate ventricular tissue early, much earlier than would have been the case than if you had waited for the signal to get through the AV node, through the His bundle, and all the way through the His-Purkinje system to activate the QRS in the normal route. And as a consequence, the HV interval can be short when you have an accessory pathway conducting in the forward direction. And that reflects the earlier activation of the ventricle. That V part of the HV interval comes early. So that HV interval may not be 40 to 60 milliseconds, but early. And in fact, if you take so long to get through the AV node that the accessory pathway, when it's present, gets to the ventricle even before you got to the His bundle, you can have a negative HV interval, which is the case that I'm showing here in this example. The yellow line is at the beginning of the His bundle deflection, and the blue line shows the beginning of the QRS on the surface, which is all the way back here. There's an initial slope, that's the delta wave, that's the initial slope portion of the QRS on the surface EKG, and that can happen even earlier than the His bundle if the accessory pathway is able to conduct to the ventricular tissue even before you got through the AV node. In contrast to the case I just showed, where there was a dramatically short HV interval, in fact, it was even negative, there are cases that are borderline, and you have to ask yourself in these cases whether or not I'm seeing evidence of an accessory pathway conducting in the forward direction. For example, in this case, when you look at the timing from the beginning of the His bundle to the beginning of what looks like the beginning of the QRS on the surface, you're getting a number that's just a little bit shorter than normal. It isn't 40 to 60, but it's a little bit short, in this case 28 milliseconds. And the first question you may ask yourself, well, am I accurately even measuring to the beginning of the QRS? Is this a second part of the P wave? Nah, it looks like the beginning of the QRS here. Or am I just simply making a slightly abnormal or inaccurate measurement if it's only slightly short? And so really what you're asking here is, am I pre-exciting the ventricle in this case? Am I somehow getting to the ventricle early through an accessory pathway, which may be contributing only a minimal amount to the QRS? Here the pink reflects ventricular muscle activated through the pathway system, and the yellow is giving you the QRS activated through the His-Purkinje system. And so the QRS may not look that abnormal at all. And so really what you're asking, is there a tiny little bit of evidence that the accessory pathway, if present, is contributing to the QRS? Well, there are ways to figure this out. How do you reveal whether a mildly short HV interval and a mildly abnormal beginning of the QRS reflects just a variation of normal, or whether there truly is an accessory pathway? One way to do it is to disable temporarily the AV node by giving adenosine. And what you're going to be doing here is, if you block the AV node completely, then you're going to exclusively allow conduction over the accessory pathway. And what will that look like? Well, you certainly will have a much wider QRS because you're no longer taking advantage of the rapid transit His-Purkinje tree, but instead you're conducting over the pathway and inserting directly into ventricular muscle. You'll still get to the entire ventricle, but in the same way that a PVC would if it were to come from this place of insertion of an accessory pathway. So you'll get a very wide, unusual looking QRS, even though it is conducted through an accessory pathway. In addition, you'll see an exceptionally short PR interval because you have no delay getting from atrium to ventricle through the accessory pathway, which typically does not have the same slow conduction as the AV node does. And in this example here, we have a patient with what looks like sort of a short PR, and maybe there's evidence on the surface EKG of a little delta wave, or maybe not. But once we give adenosine, the answer is clear. We have intact AV conduction during the temporary and full disabling of the AV node, but the QRS looks wide and extremely bizarre and abnormal. The PR is short. We don't use the His-Purkinje system because we're only going over an accessory pathway, and this makes it completely obvious that indeed we have an accessory pathway present while the AV node was disabled. And then the adenosine wears off and you go back to the same baseline QRS with its very, very subtle delta wave seen on the QRS complexes. In the EP lab, you can again give adenosine and do exactly the same thing, or you can take advantage of having catheters in the heart and do other maneuvers to demonstrate the same thing. The first thing you can do is you can take advantage of that decremental property of the AV node. Instead of just allowing sinus rhythm to occur, you can pace faster a number of atrial beats in a row, which will cause decrement and even slower conduction through the AV node, and that will give more opportunity for an accessory pathway, even one that's far away from the sinus node or from the pacing site, give more opportunity for that accessory pathway to activate the ventricle. Your QRS will therefore be wider, you'll have a much more prominent delta wave, and your HV interval will shorten further. Another way you can use a maneuver, a pacing maneuver in the EP lab, is to pace closer to the pathway, pace the atrium from different sites, and take advantage, even if you don't pace fast, take advantage of the proximity of the pacing site to the atrial end of the pathway, in which case, again, you will give an advantage to the accessory pathway to conduct, even if you aren't decrementing in the AV node. You can again have a more prominent delta wave, a shorter HV, because by pacing close to the pathway, you can dominate a little bit more the activation of the ventricular tissue through that pathway and have a little bit of a less contribution of the His-Purkinje system. In this particular case here, we did both. We paced from the distal coronary sinus, which is in the left atrium, and we paced faster than sinus rhythm, and look what happened. These two images are just a minute apart. And here we are pacing in the atrium. How do I know that? I can see the pacing artifact here in coronary sinus catheter 1-2 that is in the distal coronary sinus, and it captures left atrial tissue. And we can see here the very beginning of the P wave after atrial pacing occurs. And look at what happened to the shape of the QRS. It's wide and bizarre because it uses very little, if any, of the His-Purkinje system, because we are giving every advantage to this left-sided accessory pathway by pacing close to it and by pacing the atrium faster and decrementing in the AV node, giving even more opportunity for the accessory pathway to dominate. And here, if we measure the HV interval in this scenario, we have shortened it and in fact, again, have shown a negative interval from the timing of the His bundle to the beginning of the QRS on the surface. You have a negative HV, solidifying very clearly the diagnosis of an accessory pathway conducting in the forward direction. There are many patients, though, who have an accessory pathway that conducts only in one direction. And that's the next question that we ask in the EP study. Is there a backward conducting accessory pathway? It's interesting to think about different populations of patients and the type of accessory pathways that are present. For example, when you think about the pediatric population, children who have WPW and SVT, first of all, you're more likely to present with SVT when you have a pathway that conducts in both directions earlier in life, and certainly it's much easier to pick it up if you can see an overt delta wave, WPW, on an EKG. Because if you conduct in both directions, again, you're more likely to see the delta wave for all the reasons we've discussed. And so in the children who have SVT due to AVRT, those are easy to pick up, and they often get treated with catheter ablation, which is curative in childhood. As you get into the more adult population, you're more likely to see pathways that conduct only in the backward direction. These are called concealed accessory pathways because they don't create a delta wave on the surface EKG, because when you have sinus rhythm or any beats that come from the atria, premature atrial beats, you still only conduct through the AV node in the His-Purkinje system with a normal PR interval, a narrow QRS, because you are unable to conduct in the forward direction in the concealed accessory pathway scenario, and therefore you have no impact on the PR interval or the appearance of the QRS, and no delta wave is present. And so when you have an SVT study in the adult population, or in the pediatric population as well, you also have to ask the question, once you prove that there is no accessory pathway present in the forward direction, does this person have a pathway in the retrograde direction? Because the most common pattern of AVRT, as we discussed at the beginning, is ORT, orthodromic, down the AV node in His-Purkinje system and backwards up an accessory pathway. So a concealed accessory pathway is perfectly capable of resulting in SVT, just as an overt bidirectional accessory pathway is able to. As we think about whether a concealed accessory pathway is present, we have to think in reverse. We have to think about how signals get from the ventricles to the atria when we're pacing in ventricular tissue, because that's the only way we're going to distinguish whether a concealed accessory pathway is present or whether only an AV node connection is present in the retrograde direction. And it's also important to consider that accessory pathways, whether they are overt or concealed, can be present in different places of the heart. You can have an accessory pathway that is present over on the left side of the heart, connecting left ventricle to left atrium. You can have an accessory pathway that connects the right ventricle to the right atrium over lateral, way away from the septum. Or you can have an accessory pathway in the center of the heart, right next to or nearby where the AV node is located. And so as we try to find whether an accessory pathway is present in the reverse direction, we have to again think about VA conduction, and we have to therefore pace in the ventricle and look at how signals are getting from ventricle to atrium. And the very basic first step is to look at where is the earliest atrial location to be activated if we have VA conduction present. If you see that the atrium is earliest in activation over here, way away from the septum, over on the right side of the heart while you're pacing in the ventricle, that tells you you must have an accessory pathway present, because that's not where the AV node is located. The AV node, as we reviewed, is right in the center of the heart. So if you have what we call eccentric activation, if you have activation of the atrium away from the center over here on the right side, that tells you that an accessory pathway on the right side must be present. Conversely, if we have eccentric activation over here on the left side, the earliest atrial activation is way out here, far away from where we know the AV node is located. That tells you you must be getting to that atrial tissue early through an accessory pathway. If you activate the atrium during ventricular pacing somewhere at or near the center of the heart, that could be over an accessory pathway. That's called concentric activation. You're activating the center of the heart first and then going both over rightward and over leftward simultaneously from that early spot. But that can look identical or very similar to how conduction would occur over the AV node, which also inserts into the center of the heart and giving you concentric activation of the right and the left atrium over rightward and over leftward at the same time. And so how do we determine where is the earliest site of atrial activation? Well, that informs in part where we put catheters during a standard EP study looking for SVT. We put a atrial catheter in the high right atrium, which is over lateral, so we have information from over at the lateral portion of the right atrium. We put a catheter up in the coronary sinus and thread it in that AV groove along the coronary sinus between the left ventricle and the left atrium with the tip over here out lateral. And we put, as I showed before, a catheter right in the center of the heart across the tricuspid valve, right near where the His bundle sits, near atrial tissue at the septum and near ventricular tissue at the septum. And now when we pace in the ventricle, we can sample and look at atrial activity in these different catheters and determine what is the earliest spot and what is the sequence of activation, the order of things, and that can help answer this question whether we have a retrogradely conducting concealed accessory pathway. So let's get right into this question of VA conduction, whether it is present and how the atria are activated. When you're faced with intracardiac recordings like this, my recommendation is that the first thing you should look at is the surface EKG leads to figure out what's going on and then move to the intracardiac electrogram part of the tracing. The surface EKG leads are usually at the top of the screen. In this case, we have leads 2 and AVF and V1 displayed. And as we look from left to right, we can see that there are 5 beats in total on the page. The first 2 of them are sinus beats. We know that because there is a P wave in front of a narrow QRS. The P wave morphology is positive in the inferior leads. It is biphasic in lead V1, and therefore those are sinus beats. And then we have 3 ventricular paced beats. How do we know that that's ventricular pacing? Several ways. We can see that there's a pacing artifact before a wide QRS. We can look and see that there is artifact in the RV apical catheter, we can see that there is in the stimulation channel S1 beats being reported to occur, but all of those pieces of information together show you that we have ventricular pacing. The next thing you look at is the intracardiacs and figure out where the atrial events are to see whether VA conduction is present at all, and if so, what is the earliest part of the atrium to be activated. Let me assist you by putting green boxes around the atrial electrograms. You can see here in the first 2 beats that the sinus rhythm starts near the high right atrial catheter, runs across the right atrium, and then the atrial electrograms in the His catheter are seen next, followed by the electrograms in the coronary sinus from the proximal electrode CS910 all the way across the left atrium to the very last part of the atrium to be activated, the lateral left atrium. In the 3 beats on the right, which are ventricular pacing, we can see that we have an atrial beat following each ventricular paced beat. How do we know that those are not sinus beats? We know that in several ways. Number one, and most importantly, is we have accelerated the atrial rate to the ventricular pacing rate. How do we determine that? We can see that there is a fixed interval between the ventricular pacing and each atrial beat. That's one way to think about it. Another way to think about it is that the AA interval is the same as the paced VV interval. So we've accelerated the atrial rate to the ventricular pacing rate. But another way to look at it is the activation sequence during ventricular pacing. If we look at the high right atrial electrogram, for example, as I said before, during the first 2 sinus beats, that is the very first atrial electrogram to occur near the beginning of the P wave. But notice how on the latter 3 beats that HRA signal is late after the atrial signal in the coronary sinus catheter, for example. One question that people sometimes ask is, wait a minute, if we have this activation sequence in the coronary sinus during sinus rhythm, how come it's exactly the same during ventricular pacing and VA conduction? Shouldn't it be the opposite since we're going upward instead of downward? And so let me show you an image to help explain why that is the case, even though you do have retrograde conduction and upside down P waves on the surface EKG if they're visible outside of the QRS complexes. When you think about the recording sites in the atrial catheter, the high right atrial catheter, the His catheter, and the coronary sinus catheter, and you think about where the atrium is first activated in the sinus node scenario and in VA conduction, let's see what the activation sequence is in the coronary sinus in the normal heart. Here is sinus rhythm, where we start in the sinus node, and again we have HRA first, and then as we sweep across we have in the yellow the His catheter next, and then CS910 out to CS12, and that makes sense. But when you think about retrograde conduction up the AV node, we don't actually conduct way out here. If you don't have an accessory pathway out there, you conduct up the center of the heart. So even though you have backwards conduction, retrograde conduction from V to A, you're not reversing entirely the activation of the atria, but instead you're coming up the center of the heart. The right atrium is backwards in its conduction, but the left atrium is actually, from the right to left perspective, still in the forward direction even during retrograde VA conduction up the AV node, and that explains why the CS catheter has the same activation sequence during VA conduction as it does during sinus rhythm when you traveled across both atria sequentially. But it is important to look at the relative timing of electrograms because the HRA catheter in the retrograde direction up the AV node is late, as in contrast to sinus rhythm where it is the first electrogram to be inscribed. So let's look at an unknown example of a patient undergoing an EP study for SVT. And as I mentioned before, let's start looking at this complex tracing by looking at the surface EKG leads so we understand what's happening. We can see the 3 EKG leads displayed here, leads 1 and 2 and V1. We can see that there are 4 beats on the page. We can see that the first 3 beats have a pacing artifact followed by a wide QRS in front of each, and we can go to the bottom and see that There are stimuli being delivered. Here is the 7th and 8th S1 beats followed by an S2 beat with a shorter coupling interval, and we can see this big artifact in the RV apical catheter, again confirming that we have ventricular pacing. And then the last beat on the page has a P wave followed by a more narrow QRS, so that's likely a sinus beat. And in fact, if we skip to the intracardiac electrograms on that last beat, we can see that the high right atrial catheter is first, followed by the atrial deflections in the His catheter, followed by CS 910, 7-8, and out to 1-2, all consistent with right to left activation of the atrium, followed by a His deflection and a QRS. So this is a sinus beat over here on the right, but let's focus on the ventricular pacing on the left as we answer the question whether or not there's a concealed accessory pathway. Those are the 3 paced beats. And here are the ventricular events that correspond to those 3 paced beats. And let's look then at the atrial events to figure out the activation sequence in the atrium as we conduct retrograde. Well, I guess the first question is, are we conducting retrograde? And the answer is yes. How do we know? Let's look at the activation sequence. We can see that the earliest atrial electrograms in these 3 beats are all in the His catheter, followed by CS 910. The high right atrial electrogram is late in contrast to the sinus beat, so we know in fact that these atrial events that follow the ventricular paced events are in fact conducted in retrograde fashion. So VA conduction is present. The next question that we have is, how are we getting back up to the atrium? And we sort of alluded to that already, that it isn't early in the HRA. But as we think about which electrodes are earliest, we can see, as I mentioned, that the His catheter atrial electrograms are the earliest, followed by CS 910, and going outward from the center of the heart this way, and also the HRA catheter is late, so you're also going out this way. So it looks like we're conducting retrogradely up the center of the heart, and again we call that concentric activation of the atrium or central activation of the atrium. But as I mentioned a few slides ago, that is insufficient to distinguish whether we're conducting up the AV node or if there is an accessory pathway that's concealed that's also near the septum in the center of the heart. How do we tell the difference? Well, then we rely on the properties of the AV node versus the properties of an accessory pathway. The AV node conducts in a very specific way. When you hit it faster, it conducts more slowly. We said that is called decremental conduction. So let's measure the VA time on these 3 beats. In the 8 beats in a row that we first paced in the ventricle, the S1s or the V1s, the VA time as measured from the pacing stimulus to the earliest atrial activation is consistent at 170 milliseconds. However, on that early S2 challenge beat where we paced a little sooner, we have a much longer VA conduction time of 290 milliseconds. That tells us that VA conduction is also decremental, which is characteristic of conduction through the AV node. So as we have done the sequential pacing maneuvers with S1s and S2s, with the S2 coming in earlier and earlier, we would have seen that the VA time got longer and longer until we reached this point, showing that in fact we're conducting retrograde up the AV node. Another little trick that sometimes can help save time or at least confirm what you're seeing with the calipers is correct is you can actually look at, without even having to measure, the relationship between the ventricular electrogram and the atrial electrogram in a catheter where you see both. In this case, the CS1-2 pair of electrodes out distal is capturing some far field ventricular signal that times with the QRS, and the near field sharper atrial signal that times with the retrograde P wave, and we can see visually, even without using calipers, how dramatically different the VA time is on these S1 beats versus the S2 beat. So it's very obvious in this example that we have decrement and central conduction and no evidence of an accessory pathway. Here's another example, and let's do the same analysis in this patient. The way the screen is positioned, we actually have 4 paced beats. Let's start again by looking at the surface EKG. Here we have 4 different EKG leads 2, AVF, V1, and V6. We can see a pacing artifact in front of each of these. We can see the S1 stimulus labels followed by an S2. We can see the big pacing artifact in the RV apical catheter. These are all ventricular paced beats, with the last one being early, that test pulse. Let's look at the atrial activation and see, first of all, if we have retrograde conduction or not. Here we are. We have an atrial event after each ventricular event, and when we have an earlier ventricular event on the S2 beat, we have an early atrial event. So in terms of the timing, we clearly can show that we do have VA conduction. We can also see that the HRA catheter is late, so these are clearly not sinus beats. All the evidence points to VA conduction being intact. The next question that we ask is, what is the earliest atrial activation? As we answer the question, is there evidence of a concealed accessory pathway? Let's think again about where our electrodes are placed, figure out where the atrial electrogram is earliest, and that can give us a clue as to how we're getting from ventricle to atrium during ventricular pacing. It looks like we have earliest activation, probably, it looks a little later in the His catheter, and maybe it's earliest in either CS910 or CS78. Remember, it's important to distinguish ventricular from atrial electrograms. The ventricular electrograms are more far field. That's these. The atrial electrograms are sharp. It can be a little difficult to distinguish one from the other, but these are later. It looks like the earliest sharp atrial electrogram is probably here. So if we think about how we're getting from V to A, it's somewhere in the CS78, CS910 area. It's just off the septum, but as I talked about atrial anatomy, some people do have a leftward extension of the AV node, and it also depends on exactly where the coronary sinus catheter is positioned. If CS910 is right at the septum or hanging out in the right atrium a little bit, or pushed into the coronary sinus a little bit, I would still call this, even though the His catheter is a little bit late, I would still call this a central or a concentric activation of the atria, because it's certainly still possible that we're close to the septum, that this could be an AV node extension. So I wouldn't say this is far enough leftward to rule out the possibility of retrograde conduction over the AV node. But the next question, though, since we have central or concentric retrograde activation, is how is this retrograde conduction occurring? Does it have properties that look like AV node properties, or does it have properties that look like an accessory pathway? And that's where this question of decrement comes into play. If we look at the timing between the ventricular pacing stimulus and the earliest atrial electrogram in the S1 beats compared to the test S2 pulse, we can see that it is unchanged. It is fixed. There is no evidence of decrement in this case. This was true as we came in earlier and earlier on that V2 beat, and even at this point where we have a pretty short coupling interval between that last S1 and the S2 ventricular pacing stimulus, we are not seeing decrement. That is consistent with conduction over an accessory pathway. We would have expected that VA time to prolong if we were conducting over the AV node. So even though this is relatively central or concentric in atrial activation, it seems from this maneuver that we likely have conduction over an accessory pathway that is close to or near the AV node and near the septum. Again, non-decremental conduction. The other thing that I mentioned before in terms of eyeballing this VA time, we can use that far field ventricular signal and the near field sharp atrial signal before you even take out the calipers to see that in fact this looks like a pretty fixed interval between them, and therefore you can just tell that there is no decrement. But of course you should make that measurement to be sure. Here's another example where we're looking at baseline ventricular pacing to answer the question, in this patient with SVT, yet a different patient, do we have VA conduction, and how are signals getting from V to A? Let's start first with looking at the surface. Leads 2 and AVF and V6 are displayed. We have the pacing artifact, the wide QRS that comes first, the S1 labels, the artifact in the RV apical catheter. So this is ventricular pacing. Here I'm going to identify the atrial electrograms here. These are far field ventricular electrograms. These are sharp atrial electrograms. The HRA is late on each of these beats, so these are not sinus beats. And if you look at the AA intervals, they match the VV intervals. There's also in this S1 train, there is a fixed VA time. I didn't put calipers on it, but you can see visually that the VA relationship is fixed. These are retrogradely conducted beats, so yes, indeed, we have VA conduction present. The next question, how are we getting from ventricle to atrium? Let's again think about our electrode position, and let's look at what is the earliest atrial activation. In this case, HRA is late, and as we look at all these atrial electrograms, the earliest is actually out here in CS1-2. Where is that? That's way out over on the lateral part of the left atrium. The AV node is not over that far. Even if you have a little bit of a leftward extension, it just doesn't make it out that far with the standard electrode spacing of a decapolar catheter that's used in the coronary sinus. So this is not concentric or central conduction. This is eccentric conduction, and this right away tells you that you're conducting from V to A in a way other than through the AV node, simply because it's just too far leftward for this to be AV nodal tissue. So right off the bat, even before you put in a test S2 pulse, you can see just from the S1s that you have an accessory pathway present that conducts over, connecting the lateral left ventricle to the left atrium. Here's another example where we have 4 beats on the page. Just going to skip through this quickly because you're becoming expert on this. Here are the surface leads, pacing artifact, 3 ventricular paced beats. Here you have a sinus beat with a P wave in front of the narrow QRS with HRA early and the typical activation sequence of sinus. But let's focus on the ventricular pacing events where we have the last 2 S1 beats and an S2 beat. Here are the atrial electrograms for those last 2 beats and comparing them. Do we have VA conduction? Yes, we do. The HRA is late. And what is the earliest atrial activation here? It looks to me like it's probably, I don't know, somewhere maybe here, maybe coronary sinus 3-4, maybe slightly ahead of CS1-2. So that's pretty far over. In fact, again, probably far enough away from the septum and far enough away from where the anatomic location is of the AV node. So I can tell you, even without looking whether there's decrement or not, that this is almost certainly accessory pathway conduction, just not where the AV node is located. But let's look, given the S2 pacing pulse, whether there is decrement. If we measure the VA time between them, you can see that the VA time is fixed. I didn't put calipers on it, but there's no evidence of decrement here on this S2 beat. So we have both eccentric conduction and non-decremental conduction, very consistent and highly suggestive of the presence of a left-sided accessory pathway. Here's yet another example, a different patient still, where we have 5 ventricular paced beats on the page. I'm not going to review that at this point, but I will show you where the atrial electrograms are. Here they are. And while we have 5 ventricular events on the page, we have 3 atrial events on the page. And if you look at the activation sequence, there is no evidence of VA conduction. These are sinus beats. The high right atrium is early. Now, could you have that with an accessory pathway on the right side? Yes, but we don't have VA conduction. There is no relationship between the ventricular paced beats or these intervals and the atrial intervals, which are marching through independent, completely unrelated to the ventricular signals. And therefore we conclude we have absent VA conduction, and of course the activation sequence in the standard atrial electrograms where the catheters are placed show you that you have right to left activation consistent with sinus rhythm. Let's review a different method of distinguishing a septal accessory pathway from conduction up the AV node in the absence of an accessory pathway. That's one of the biggest challenges in figuring out how the heart is wired, especially in some people if retrograde AV node conduction is pretty quick and doesn't have as much decrement, or if an accessory pathway that's septal has a little bit of decrement, because again, there are exceptions to these rules, and sometimes it isn't so black and white. It's possible to see a little bit of decrement with central retrograde conduction, and you ask yourself, am I just seeing really good AV node retrograde conduction or slightly decremental accessory pathway conduction, and it isn't so clear? Here's another method that can help you answer that question of the presence or absence of a septal concealed accessory pathway. And it's called Para-Hisian pacing, and it's really, really cool. It's a wonderful technique that I love doing in every SVT case. When people explain this, one of the things that they sometimes forget to mention, and it is critical to understanding how this maneuver works, is the anatomy of the His-Purkinje system. The His-Purkinje system, as we discussed, is lightning fast in the forward and the backward direction. But another interesting property is that it is insulated. There is a layer of fibrous tissue that surrounds the His bundle and the proximal portions of the bundle branches. What does that mean? That means when we have beats in the ventricle that are near the conduction system, they cannot go sideways into the conduction system. You can't jump from ventricular muscle up here at the base of the septum sideways into the His bundle. You can't go sideways into the right bundle or sideways into the left bundle, or out of it for that matter. And that's important actually for the function of the His-Purkinje system. You want signals when it comes in the forward direction to go down all the way to all of these fibers and hit them at the same time. If you leaked out sideways, that would defeat the purpose of having a His-Purkinje tree. But it works in both directions. If you're insulated, that prevents signals from escaping and leaking out sideways. Likewise and conversely, the same insulating fibrous tissue prevents signals from going into the His bundle and the proximal bundle branches sideways. So if you were to pace or have a PVC beat come from the base of the septum, the way that you would get backwards up to the atrium is not to go like this if you have only the His-Purkinje system and an AV node, but instead you have to travel all the way down ventricular muscle toward the apex to find the nearest end of a Purkinje fiber that you can then enter, and then go backwards up the Purkinje fiber, backwards up the bundle branch, backwards up the His and the AV node to get to the atrium. You have to take the long way home if you're up here near the base of the heart in the absence of an accessory pathway. We can take advantage of this fact by doing a maneuver and pacing right up near the bundle of His, and let's see how that works. First, as I said, if you pace at the base of the ventricle, you're basically going to generate a PVC beat that would look the same as if you had a spontaneous beat from that location as it does during pacing from that location. And because you're not using the His-Purkinje system to generate the QRS from pacing just from myocardium, you're going to get a wide QRS, again, that looks just like a PVC. However, an interesting property when pacing at this location is if you pace with a higher output, you actually directly capture a much larger radius of tissue all at once. In fact, you can directly capture His bundle tissue if you're close enough to it with a high enough output. That's different from conducting sideways from ventricular muscle into the His bundle. This is talking about directly capturing the His bundle tissue with a very high output pacing stimulus nearby that just directly captures it. In addition to capturing the ventricular muscle nearby as well, you're capturing both at this high output. And when you do that and pace at high output, you're going to generate a QRS that is fused, the same morphology that you would generate as if you were pacing just from myocardium, like the PVC morphology here. But on top of that, you're going to capture the His bundle and you're going to conduct forward down that His-Purkinje tree. If you had captured only the His bundle, you'd generate a perfectly narrow QRS, just like conduction. But because you're also capturing ventricular myocardium, you're going to get a fused beat that's going to look partly like a narrow QRS and partly like the wide PVC beat. But it's going to be narrower than what the capture from that same location looked like at lower output where you didn't capture the His bundle. So pacing from the same location at lower and higher output, you can distinguish by the shape of the generated QRS whether you capture only ventricular muscle or whether you capture ventricular muscle and the His bundle directly. Why does that matter? Let's just look for a moment at how you distinguish one from the other. Here is pacing at the Para-Hisian location next to the His bundle, and we are changing the pacing output. Here are 4 ventricular paced beats, and you can see that the first 2 beats are skinnier and the latter 2 beats are wider, and we're pacing from exactly the same location the entire time. And that tells us that in those first 2 beats, we captured the His bundle in addition to ventricular tissue, and the third and the fourth beats, we captured only ventricular tissue. And what we were doing during this maneuver is we were reducing the output. We started with high output, capturing a larger radius, and then as we turned down the output, we shrunk the radius of capture and we ceased to capture the His tissue directly and only ventricular muscle, and therefore we generate basically a PVC-like QRS without contribution of the His-Purkinje tree. How do we know where to pace in order to have this effect at different outputs? Well, if you can see a His bundle deflection, that should indicate that when you pace at high output, you should be able to capture that His bundle. So you'd pace whether it's from a His quadrupolar catheter or whether it's from an ablation catheter positioned right near the His. Finding a place where you have a His bundle deflection is an ideal location for doing this Para-Hisian pacing maneuver, which again, we're going to review how that works. But in addition, you should not have a large atrial electrogram, because if you do, then at higher output or sometimes even lower output, you're going to capture atrial tissue as well, which, as you'll see, is going to completely defeat the purpose of this maneuver. We're going to look at VA conduction while pacing the ventricular tissue with or without His tissue capture as well. And if you capture the atrium directly, you're not going to be able to interpret this maneuver. So the ideal site for Para-Hisian pacing is a big His bundle deflection and a small or absent atrial deflection, so you don't inadvertently capture atrial tissue. All right, let's review how this maneuver can be helpful to distinguish retrograde conduction over the AV node versus retrograde conduction over a concealed septal accessory pathway. Here we're pacing in a scenario where we only have an AV node connecting V to A and A to V. And at high output, as I said, you're going to capture both ventricular myocardium and the His bundle. How do we get from this pacing stimulus up to the A? Well, we took a shortcut because we directly captured His bundle tissue. So to get up to the atrium, all you have to do is travel retrograde up the remainder of the His bundle through the AV node, which again is sort of slowish conduction, and then into atrial tissue. That's the pattern at high output. As you lower the output though, however, and you lose His bundle capture, now, as we discussed before, because of that insulating layer around the His bundle, you can't just go shortcut directly up through the AV node, but instead you have to travel down the septal tissue, find the nearest end of a Purkinje fiber, and they all insert closer to the apex, and then you can travel retrograde up that Purkinje fiber, up the bundle, up the His, and back up to the A, which is a much longer route, and therefore it takes a longer period of time. So here's an example of this maneuver done in a patient with an AV node and no accessory pathway. Let's first look at the 4 beats that are displayed and figure out which ones capture the His and which ones don't. You can see a clear difference in the width. The first and the third beats are capturing the His as well as ventricular myocardium, and the second and the fourth are capturing only ventricular muscle. We probably have right now a pacing output that's just hovering around the pacing threshold, the pacing radius of capturing the His bundle, and some beats are capturing it and some beats are not. I like to always have, when I'm doing this maneuver, 4 beats seen at once, 2 of which are capturing the His and 2 of which are not, so that I can be sure that the measurements that I make are reproducible and we're not being fooled by a coincident premature atrial beat or any other distraction that is not consistent with the maneuver we're intending to perform. So now that we know which beats are capturing His and which ones are not, let's measure the VA times. Notice that the first and third beats where we capture the His, we have a stimulus to earliest A timing of 70 milliseconds, and on the 2 wider beats where we lost His capture but maintain ventricular muscle capture, we jump out to over 100 milliseconds longer here, 175 milliseconds. And so this is exactly the pattern I just discussed, where you capture the His bundle and shortcut up through the AV node when you have a narrower QRS, but if you lose that His bundle capture, you have to go all the way around the mulberry bush to get back up to the atrium, because there's no other way to get from V to A. This is consistent with an AV node pattern of Para-Hisian pacing, and it argues against an accessory pathway. Another interesting finding on this page is to notice that when we lost His bundle direct capture and we had to go all the way down and all the way back up, we actually can see the His bundle deflection late after you did this whole route and you lost that little extra signal on the 2 beats where you captured it directly because it was pulled into the pacing stimulus. You captured the His directly, but on the 2nd and 4th beats where we didn't capture the His, and you're lucky, or sometimes you need a second catheter to see this really well, you can see that His bundle deflection out late because again you activated it late once you went down and then all the way back up. Let's review the same maneuver in the presence of a concealed septal accessory pathway. Here's the pathway just close to the septum. It's just easiest to draw it a little bit separate from where the AV node is. And we're going to do exactly the same maneuver where we're going to pace at very high output in a catheter that shows a His bundle and very little, if any, atrial signal. And we're going to lower the output. But when we capture the ventricular muscle and the His, we are able to get up to the atrium in 2 different ways. We can go up as before, the remainder of the His bundle through the AV node to atrial tissue at this high output pacing, but also we can sneak directly, as this is like an easy pass lane, we can go directly back up to atrial tissue through this accessory pathway. And in fact, that's probably a little faster usually than going up the AV node, because AV node conduction is slower typically than accessory pathway conduction, and they're both right in the neighborhood, and so you have a relatively short VA time. What happens though when you lower the output and you capture only ventricular muscle? Well, in this case, in order to get up the AV node, you'd have to conduct all the way down ventricular muscle to go backwards. But because of the presence of the accessory pathway right there, you can still, even with just ventricular muscle capture, conduct easy pass lane right back up to the atrium, even though you're not capturing the His bundle. VA conduction is not contingent upon direct capture of the His because of the presence of the accessory pathway. Let's look at this in a real-life example. Here are 4 beats, as is my preference, and let's look at which ones capture the His and which ones don't. In this case, the 2 that capture the His that are narrower are the 1st and 2nd beats, and then as we came down on the pacing output, we lost His capture, as indicated by the widening of the QRS on the 3rd and 4th beats. Okay, let's measure the VA times and see how they compare. Here, the VA time on the first 2 beats is 115 milliseconds. We're again measuring from the pacing stimulus to the earliest atrial activation, which here is in maybe CS5-6, maybe close enough to the septum for this to be a leftward extension of the AV node. However, we can see that when we lost His bundle capture with the wider QRSs, that had no impact on the VA time. It's still 115 milliseconds. What does that tell us? That tells us that the timing from V to A pacing at the Para-Hisian location was not contingent upon direct capture of the His bundle, but instead you were able to sneak up directly up an accessory pathway, regardless of the His bundle capture, and therefore this fixed VA time with both His and non-His capture shows us that we have an accessory pathway present. Now that we've answered the question of whether there is an accessory pathway in the forward direction and whether there is an accessory pathway in the retrograde backward direction, the next question that you'd ask in an EP study for SVT is whether the AV node has two separate components or not, that being necessary for the AV and RT mechanism of SVT. This is also called dual AV node physiology. How do we figure it out? Let's have a look. So how do we determine if we have conduction through the AV node with one component or two components? The best way to think about this is with this classic graph from the Josephson text, which I've modified a little bit so that we focus on one thing at a time. The way we're going to test the AV node is by going back to our programmed stimulation with A1, A2 pacing. We're going to deliver a series of A1 pulses, usually 8, that's called the drive train, and we're going to deliver a test pulse, an A2 beat in the atrial tissue, and that's going to be shortened and shortened. That A2 interval will become earlier and earlier, and we're going to see what happens to AV node conduction during all of those A2 test pulses, and we're going to graph it, and it's going to visually show us the difference between normal AV node behavior and behavior of an AV node that has two components. While we do this, we're going to be measuring the AH interval, and as you recall from my introduction to electrograms video, the AH interval reflects the time it takes to conduct through the AV node from atrial tissue on the one side through to the His bundle on the other side of the AV node. So let's start this graph with an A2 interval at 600 milliseconds, and as we measure the AH interval at that test pulse, it's about 100 milliseconds, that AH interval. And what's happening on that beat? Well, what's going on is we are conducting forward through both the fast and the slow components of the AV node. I've drawn the fast here in blue and the slow, this right inferior extension, in green. Both of these feed into the His bundle, but as we deliver an A2 test pulse and we go down both components of the AV node with these longer intervals, it is of course the faster component that is going to win the race and conduct through to the His. And the slow component is going to get through the slow tissue to some degree, but it's going to meet refractory tissue because we've already been there with the fast pathway, and there in fact may be retrograde conduction up into the end of the slow component of the AV node in the backward direction, and those two wavefronts are going to collide, and you're not going to see any evidence of slow pathway conduction in this longer pacing interval scenario. What happens when we deliver a slightly earlier A2 beat? What we're going to see is the usual behavior of the AV node, which is decrement. That AH interval is going to slightly prolong a little bit as we hit the AV node a little bit earlier, and that reflects decremental conduction in the fast component of the AV node. That is the reason for this AH interval. And as we pace a little bit earlier still with an A2 beat that's earlier, we're going to decrement a little further with a slightly longer AH interval. And then again, as we pace a little bit earlier with the next A2 beat, we're going to get yet a little slower, a little longer AH interval in the AV node, and so on and so forth. So as we continue to bring in that A2 beat, we're going to see decrement, further prolongation of the AH interval. This is normal AV node behavior in people who have no slow pathway component or people who do. This is consistent across all people with an AV node that functions. Is you're going to see this decremental pattern. The earlier you hit the AV node, the longer it takes to conduct. But in somebody who has two components of the AV node, you're about to get a surprise. As you pace yet slightly earlier, perhaps yet another 10 milliseconds sooner, you're going to see a big change in the shape of this graph. Instead of seeing the next AH interval be right on this sort of trajectory, you're going to see it suddenly change to a much longer AH interval. What happened in this scenario? Well, this reflects refractoriness of the fast component of the AV node. We blocked in the forward direction in the fast because we reached the point where this fast pathway is refractory. And by the way, that's the irony of the AV node, is that the component that conducts faster has a longer refractory period than the component that conducts more slowly. So as we block in the fast part of the AV node, we now give carte blanche to the slow component of the AV node to conduct with its slower timing down to the His bundle. So the AH interval that is now generated is much longer than it was when we were conducting down the fast because the slow pathway is slower. And that is in fact reflected in the effective refractory period of the fast pathway. Again, when you see this sudden change, that means we blocked in the fast. That's the effective refractory period of the fast pathway. And now we're exclusively conducting through the slow. And as we continue to bring in that A2 beat, we're going to see that same type of AV node decremental behavior in the slow pathway. So you're going to see this more predictable slope resume, even though all of these AH intervals are now longer because we're conducting through a slower part of the AV node. So the graph of somebody who has two parts of their AV node has this initial component, which reflects fast pathway conduction, and then this other component that reflects slow pathway conduction. So how do you define how big of a change you need to see to say, yeah, we really are dealing with two different components of the AV node? To call this what we call an AH jump, that is defined as a change that is more than 50 milliseconds in the AH interval when you've only decreased the A2 beat by 10 milliseconds further. So as you come in by 10 milliseconds, if you jump up in the AH interval by more than 50, that defines a jump, and that defines the presence of a slow component, a second component of the AV node. So again, this part of the graph is fast pathway conduction, and the slow pathway is kind of working in the background. We just don't see it. And then this part of the graph shows the slow pathway. What's happening, by the way, to that slow pathway conduction? It, by the way, was also sort of happening in the background, but we just don't have a catheter. There's not a way to detect conduction in the slow pathway. But if we could back extrapolate, if we didn't have a fast pathway, what would have been happening here in the slow pathway would have been decremental conduction with faster intervals back here. And that was slowly prolonging, but there was no evidence of that because the fast pathway was faster and it was dominating in getting to the His bundle, so we didn't see any evidence of this happening, but this is probably what was happening in the background. It is only when you get refractoriness in the fast pathway and you conduct only down the slow that you can start to get SVT from AV node reentry going. Why is that? In order to get any reentry circuit going, you have to have block in one limb of the circuit and conduction in the other limb. If you're conducting down both, that will not allow for reentry because you'll get a collision on the other side of things. But once you block in one component and conduct down the other, you can then get reentry going. So in this graph, you'll only see evidence of SVT in the AV and RT scenario when you've blocked in the fast pathway and conduct only down the slow. So now that we've seen what this looks like in graph form, let's see what it looks like in the EP lab. Here's a patient undergoing an SVT EP study, and we're giving A1, A2 pulses, and we can see here on the surface EKG, here's a pacing stimulus that precedes a P wave, another pacing stimulus that precedes a P wave, and there are narrow QRSs after each. We can also see the large pacing artifact in the high right atrial catheter reflecting pacing from that location. We can see that we're annotating the last of the 8 S1 beats here and this A2 or S2 test pulse in the atrium. So A1, A2 pacing. And let's look at what happens in the His bundle catheter. I've labeled for you the atrial electrogram, the His, and the ventricular electrogram. And again, the AH interval reflects the time it takes to get through the AV node. On all of the 8 S1 beats, the AH interval is seen here. And as we pace a little bit earlier in the A2 pulse, we see a little bit longer AH interval here. And that reflects, again, the decrement from the drivetrain to this A2 test pulse. And this, by the way, interval would have been shorter and shorter with longer S2 pulses. I'm just showing you a sooner pacing pulse to compare to the next one that I'm about to show you so that we see what this jump looks like with respect to intracardiac electrograms. So here is the 600 380 millisecond A1, A2 scenario. Here's the 600 370 millisecond scenario, and I've labeled again the AH and V on the last S1 beat and on this S2 beat that's now just slightly earlier. And look what happened here to the AH interval. Did we jump out 50 milliseconds? Way more than that. Here the AH interval went from 170 to 285 milliseconds. And again, that was only with a 10 millisecond difference in that A2 interval. This is proof, evidence that we have two components of the AV node. This was the last scenario where we conducted through the fast component of the AV node. We reached refractoriness when we gave an A2 pulse at 370 milliseconds in that fast pathway, and we still have preserved conduction in the slow part of the AV node, but it takes much longer to get there, and therefore your AH interval is much longer. This is a jump. This is evidence of dual AV node physiology. Let's look at what that looks like leading up to the jump. I just showed you the interval right before and after the jump, but in the EP lab, you're going to be starting with much longer A2 intervals to begin with, and you're going to see, as in that first portion of the graph, decrement and gradual prolongation of the AH interval as you get earlier and earlier. Let's see what that looks like. Here is an A1, A2 pacing train, the last two A1s and the A2. Here's the AH interval, and let's see what happens to this interval as we bring in the A2 earlier and earlier. Here's an earlier A2, we decremented. Here's another earlier A2 still, we decremented a little bit more. Here's another earlier A2, we decremented a little more. Here's another A2, we decremented a little more. Whoop, look how much that jumped out. That was another 10 millisecond decrement in the A2 pacing pulse, and we jumped way out. That's in real life what it would look like in real time with your EP study. As you came earlier and earlier, you would see a sudden jump out. That is that jump, that AH jump that suggests you have two parts of the AV node. Let's kind of zoom in and think of what is happening anatomically during this switch from fast pathway to conduction to slow pathway conduction, because we're now about to see an additional feature of dual AV node physiology that we can explain best visually here. I've drawn in two components of the AV node, the faster in lighter blue and the slower in darker blue. And as I showed in the previous graph diagram, when we are conducting down the fast pathway and get to the His, we're going to have a collision point as you're also conducting forward down the slow pathway, and whether that's right here at the junction of the two, or whether there's a little bit of retrograde conduction from the faster conducting fast pathway backwards into the slow, and you see no evidence of slow pathway conduction at those longer A2 intervals. But again, eventually you reach the fast pathway effective refractory period, and we conduct down the slow with a longer AH. Okay, we've reviewed that already. But what's happening in the fast pathway when we conduct down the slow? The opposite thing is happening. We're actually going to have retrograde conduction back up the fast, because we blocked in the top direction. There's going to be refractory tissue there, so you're not going to see any evidence on the intracardiac electrograms of what's happening in the fast pathway at its distal portion as you start conducting down the slow. However, As you conduct even slower down the slow pathway because you've brought in the A2 beat even earlier, there's going to come a point where it takes so long to get down the slow pathway that the refractory tissue at the top of the fast pathway has now had time to recover while this is going down its slow meandering slow pathway course. And at that point, with that much longer AH interval still, you're again going to conduct retrograde up the fast, but this time you can get all the way through, even back up to atrial tissue. And what this is called is an AV node echo beat. When you conduct only down the slow and it takes long enough to allow the fast pathway to fully recover, you can go back up the fast and back up to atrial tissue. And this is what that looks like from the intracardiac electrogram standpoint. Here we are delivering A1 beats. Here are the last two of them with the pacing stimuli and the P waves. We deliver an A2 beat. We have a really long AH interval. And we notice one additional feature that we didn't see before. Another atrial electrogram that is kind of right on top of the narrow conducted QRS. And where did this atrial event come from? There is a P wave there. You can probably see a little retrograde P wave peeking out in AVF from just after the QRS. That is that AV node echo beat. We took so long to conduct forward down the slow component of the AV node that we allowed the fast component to fully recover, and we can go backwards up all the way to atrial tissue. That is another piece of evidence that we have dual AV node physiology, this time not just the jump, not just the long AH, but conducting backwards up the second component up to atrial tissue. Now you shouldn't get fooled because there are some fake outs that look like an AV node echo beat that are not, and here's one example of that. Here we have the last two A1 beats, the A2 beat. We pace here. In this case, we're pacing, by the way, from the coronary sinus, also capturing atrial tissue. You see the big pacing artifact here in CS 910 for the A1s and the A2. We have a really long AH interval. So you say, okay, we're going down the slow component of the AV node. And look here, we have another atrial event on top of this QRS. Is this an AV node echo beat? And the answer here is no, because simply having an atrial beat on top of the QRS after a long AH doesn't tell you that that's where the atrial event came from. In this case, look at the activation sequence. The earliest atrial event is not at the septum. It's not at CS 910 or in the His. It's in the high right atrial catheter up near the sinus node. This was a premature atrial beat that came from way up near the HRA catheter, not retrograde through the AV node. If this were an AV node retrograde beat, an echo, we would have expected this to be late, just like pacing in the ventricle going up to the atrium. The same thing happens when you have an AV node echo. So this is a coincidental premature atrial beat that conducts from near the sinus node, and we call this sort of a high to low beat. What we mean by that sort of slang term is that this did not come from near the AV node, which would have been kind of low in the atrium going retrograde up. And if we could see the P wave shape, we would see it would be upright in the inferior leads, not upside down like a retrogradely conducting beat would show. But interestingly, on this premature atrial beat, which by the way has an activation sequence that's very similar to the sinus beat over here, this is probably, by the way, not a sinus beat because you'd expect atrial pacing to suppress sinus node activity, and you wouldn't necessarily expect the sinus node to recover this quickly. So probably this is a premature atrial beat, but it's coming from near the sinus node with a similar activation sequence. But because this came so quickly after this atrial pacing train, the fast pathway was still refractory, and we conducted this premature atrial beat with another long AH interval down the slow component of the AV node yet again. We talked before about how A1, A2 pacing can initiate arrhythmias, and we talked about initiating reentry with a block in one of the two limbs of the circuit. And here's what that looks like with intracardiacs. Here's the initiation of AV node reentry. We have our last two A1 beats pacing in the high right atrial catheter. We have an A2 beat that blocks in the fast pathway, conducts with a really long AH interval, and gives us an AV node echo beat, which is late in the HRA catheter, kind of right on the heels of this narrow conducted QRS, a retrograde P wave in lead AVF here. But in this case, not only did we go back up the fast pathway, but by the time this all happened, going down the slow and back up the fast, the slow pathway, which has a shorter refractory period, was available again. And so that atrial beat was able to re-enter the AV node and conduct down the slow component of the AV node yet again to generate a His deflection, a narrow QRS, and that again can go back up the fast pathway. And here we are in re-entry. So we conduct down the slow, up the fast, and if each component is able to recover before the wavefront comes round again, we can be in sustained re-entry. This is sort of the holy grail of an EP study showing AV node re-entry, is being able to induce it with A1, A2 beats, showing that you had an AH jump, you had echo beats, and now you have sustained tachycardia. So let's review the findings so far. When you bring the patient to the EP lab in sinus rhythm, you put up catheters and you do baseline pacing to figure out how the heart is wired. You first look for evidence of pre-excitation in the forward direction with a short HV interval. If you're borderline or there's a question, you can give adenosine to block the AV node. You can pace faster in the atrium. You can pace the left atrium, perhaps closer to an accessory pathway, to bring out a delta wave and pre-excitation. You then look for VA conduction to see if there's evidence of an accessory pathway. And if VA conduction is present, you look to see if it's way over on the right or the left. Is it eccentric to suggest accessory pathway connection? Or is it in the center of the heart, which could be either a pathway or AV node conduction, in which case you then see if it is decremental or not. Does the VA conduction demonstrate properties consistent with the AV node or with the pathway? And you can supplement that information by doing Para-Hisian pacing to see if there's AV node or pathway retrograde conduction. Then you look in the forward direction for dual AV node physiology with A1, A2 pacing. You look and see if there's an AH jump with a critical A2 interval, and you can also see if there are evidence of AV node echo beats to suggest dual AV node physiology. If all of the above maneuvers don't yield anything, then you have to also consider the possibility that maybe the high vagal tone under anesthesia may prevent you from seeing relevant findings. And so in that case, you can give isoproterenol, which can increase the conduction properties and decrease the refractory period of parts of the AV node and sometimes even of an accessory pathway, to further flesh out how the heart is wired, just to be sure that when you have no findings, this isn't simply due to heavy anesthesia and high vagal tone. And now comes the really fun part of the EP study, which is the induction of tachycardia and figuring out what is the mechanism. You've come to this point having figured out how the heart is wired. You know if there's an accessory pathway present or not, whether there's dual AV node physiology, or both perhaps. But when you induce tachycardia, it doesn't necessarily mean that the findings until this point explain the tachycardia. You can have an atrial tachycardia in the presence of an accessory pathway or dual AV node physiology. You can have two different mechanisms of SVT. So when you induce SVT, you certainly factor in how the heart is wired, but you need to then do additional assessment of the SVT itself and maneuvers to figure out what is the actual mechanism of the clinical tachycardia. The first thing to do when you induce SVT in the EP lab is to make observations during the tachycardia itself, and also during any spontaneous changes or terminations that may occur. After that, you can do manipulations, including pacing maneuvers, but the first thing to do is just observe. And looking at the surface EKG to begin with, we see we have a narrow complex tachycardia. The next step is to look at the intracardiacs and identify atrial versus ventricular electrograms. Here are the atrial electrograms from one of the beats, and we have a 1-to-1 AV relationship during this tachycardia. And the next observation to make is where is the earliest activation in the atrium. So let's drop a vertical line at the earliest atrial activity, which in this case is out in coronary sinus 1-2, way over in the lateral part of the left atrium. You'll learn during these assessments that often you can rule out one of the three main diagnoses more readily than you can rule in a specific diagnosis. So let's think about this eccentric atrial activation sequence and what the implications may be for tachycardia mechanism. Here's a reminder of where our electrodes are located, and the red arrow shows the activation sequence during tachycardia. And let me put up my little checklist here. I'm going to be using this checklist of the 3 SVT diagnoses repeatedly because, as you'll see when we make observations, you can often cross off the list one diagnosis at a time. So what can we cross off simply from observing the atrial activation sequence in this example? The first thing to notice is that the AV node is in the center of the heart and the earliest activation is way out lateral. And so similar to our discussion during ventricular pacing and retrograde conduction, the AV node is not out there. This is an eccentric activation sequence, and therefore this cannot be AV node reentry, because if it were, you'd be activating the atrium from the center of the heart. You'd have a concentric atrial activation pattern. So as we look down at our checklist, we can cross off the list AV node reentry as one of the possibilities. That still, however, leaves 2 remaining possibilities. This could be AVRT with an accessory pathway located out here, activating the lateral left atrium early, or it could be an atrial tachycardia that's coming from the lateral portion of the left atrium. One of the things that you'll learn as we talk about activation sequence is that an atrial tachycardia can come from anywhere, any part of the atrial tissue, from the right, from the left, from the center, from the top, from the bottom. And so AT is going to be hard to rule out simply with atrial activation sequence. This is a different patient, and here we are in SVT, again with a narrow complex QRS on the surface ECG. Here is what looks like atrial activity, and let's find, by dropping a vertical, what is the earliest sharp deflection. And here we can see in this tachycardia a sharp deflection earlier than the other deflections in coronary sinus 1-2, again way out lateral. And so as we think about our checklist, once again we can cross off AVNRT as one of the possibilities. This patient actually went into tachycardia as catheters were being placed, so we actually started our recordings after tachycardia had already been ongoing. But this tachycardia spontaneously terminated, which gave us an opportunity to then look at these same electrograms during sinus rhythm, which ordinarily is the thing you would do at the beginning of any EP study. When the patient reverted to sinus rhythm, we took another look at those coronary sinus sharp signals, and we made an interesting observation. Look here at this sharp signal in the coronary sinus when you're back in sinus rhythm. It actually lines up with the QRS complex. It doesn't line up with the P wave and with the other sharp electrograms in the coronary sinus catheter. What does that mean? Well, it actually means that this sharp electrogram that we had thought in SVT was an atrial signal, turns out it's a ventricular signal. How can you get a ventricular signal from the coronary sinus catheter? Well, remember that the coronary sinus runs in the AV groove between the left ventricle and the left atrium, but as you get further away from the septum, it does tend to veer away from that groove and more over ventricular tissue. Also, you can potentially place a coronary sinus catheter inadvertently down one of the vein branches overlying ventricular tissue. And if you went back in this patient when catheters were first being placed and look at where the coronary sinus catheter was located, it was actually advanced very far in so that the tip of the catheter was overlying ventricular tissue, which explains why this sharp electrogram here is ventricular, not atrial. And then in hindsight, that completely changes how we interpret the signals during tachycardia, where atrial and ventricular signals were all on top of each other and difficult to distinguish. So we now have to uncross off AVNRT from our list, because it turns out that the earliest atrial activation may in fact be CS7-8 or somewhere closer to the septum, and that is within the realm of where the AV node could be located. So always keep an open mind and use new data as it arises, because sometimes you can be fooled. And here's another example where we're going to start by looking at the surface EKG, narrow complex tachycardia. We're going to find the atrial electrograms, and here they are. The earliest atrial activation in this case is, instead of way over on the left, it's way over on the right. If we look at where our catheters are located, that suggests an eccentric pattern starting over here far away from the septum. You have to be careful, though, by the way, that your catheters remain where you think they are anatomically. You can be fooled, for example, if the HRA catheter inadvertently had dropped down to the septum and it looks early. So you should always make sure your catheters remain located anatomically where you think they are before you draw conclusions. But here the catheter was correctly placed. And this, as we think of our checklist here, this rules out AV node reentry as a possibility, because you couldn't have earliest atrial activation way out here because the AV node is located in the center of the heart. Another observation that we have the opportunity to make during this tachycardia is the P wave morphology. The VA time is somewhat long, so the P wave isn't buried inside the QRS or inside the peak of the T wave, and we can identify the P wave shape morphologically. And in this case, it's positive in lead 1 and it's positive in lead 3. And one of the questions that then arises after we've now narrowed the diagnosis to 2 possibilities is whether you can get this P wave shape from a right-sided accessory pathway connecting, for example, to the top of the tricuspid valve. Can you get a positive P wave retrograde in lead 1 and 3? Well, people have answered that question. What do P waves look like during AVRT with a right-sided or left-sided pathway, for that matter? And here is a table generated from this manuscript in 1997, where they looked at the P wave morphology in these EKG leads, looking at accessory pathway location and what the P wave vector is in all of these leads listed above. So let's think about our example where we had a P wave that was positive in lead 1 that narrows down the possibilities of where an accessory pathway could have inserted into atrial tissue. And we had said then that our P wave was also positive in lead 3. But look, there's no combination of positive in 1 and positive in 3 that was seen during right-sided accessory pathways. And therefore we can conclude, again, maybe put a little asterisk by it and do other maneuvers to prove this, but we can strongly suggest that this tachycardia is not going to end up being AVRT, because this P wave morphology is not consistent with retrograde conduction over a right-sided pathway according to existing data and the anatomy that we know the heart follows in terms of P wave morphology and where pathways can be located. So if we cross off AVRT, we're left with only one conclusion, that being atrial tachycardia. There are other maneuvers that we'll talk about that you can distinguish AVRT from atrial tachycardia, but the P wave morphology should not be overlooked, and in this case was very helpful. Another important observation to make during tachycardia is that of the AV timing, the AV relationship, how close the P wave is to the QRS, and whether there's always a one-to-one relationship. Here, as we start with the surface EKG, we see 4 QRS complexes, even while there are more numerous atrial events. So there's a missing QRS here. What does that mean in terms of the possibilities for tachycardia mechanism? Here are our 3 options as usual, and is there anything that can be crossed off when there is not a one-to-one relationship between atrial and ventricular activity? Let's think for a moment about the AVRT mechanism of tachycardia. Here we have a circuit going down the His-Purkinje system, across ventricular muscle, up the accessory pathway, across atrial muscle, and back to the AV node. Think about that circuit for a moment and what I just said. Part of that circuit was ventricular tissue. In order for AVRT to occur, you have to exit the nearest Purkinje fiber, traverse ventricular myocardium to get to the ventricular insertion of the accessory pathway, to then complete the circuit and come back around to the AV node. That means that in AVRT, you must have a QRS, you must have ventricular activation with every single beat. And in this case, where we're missing a QRS, it is therefore impossible for this tachycardia to represent AVRT, and we can cross it off the list. What observations can we make that can perhaps rule in or rule out the other 2 possibilities? Let's look for a moment at the AV relationship leading up to the missing QRS complex. Notice that the AH interval is prolonging, the PR interval is prolonging. That suggests there's decrement during tachycardia between atrial and ventricular activation. You can see this in AV node reentry. It would be highly unusual. That would have to imply that the circuit within the AV node has tissue below it before you get down to the His bundle that is decremental. There must be some lower common portion of the AV node below where the circuit turns around. Can you see that in AV-NRT? I guess it's theoretically possible, but it seems pretty unlikely. I don't think I've ever seen or heard of a case that was Wenckebaching like this in a sustained fashion that was AV node reentry. So I guess I'll put sort of a partial cross-off for AV-NRT. But another observation that we can make during tachycardia is one we've already discussed, which is the atrial activation sequence. Here, the earliest atrial activity is in the high right atrial catheter. Again, we're talking about an eccentric pattern, way over from the right, far away from the AV node, and therefore we can be, I think, more definitive here in fully crossing off AV-NRT as a possibility. And now that we've eliminated 2 out of the 3, that leaves atrial tachycardia as the diagnosis. Here's another patient that has a non-one-to-one relationship between atrial and ventricular activity. In fact, as we look at the surface EKG, you have only half the number of QRSs as you have atrial events on the intracardiacs. You have a 2-to-1 AV relationship. And as we already discussed, you can immediately cross off the list AV-RT because you cannot have missing QRS complexes and have this be AV-RT because the ventricular muscle is necessary for that circuit. What about AV-NRT? Is it possible to have AV-NRT with a non-one-to-one AV relationship? Well, think of the AV-NRT circuit within the AV node. Is it possible for you to conduct down and have block down to the ventricles and have AV-NRT sustain? Absolutely. You could have block in the His bundle or in the bundle branches and still have the AV-NRT circuit intact. So you absolutely can have a non-one-to-one AV relationship and still have AV-NRT sustain. And in fact, when we look at the His bundle recordings, you can see there are His bundle deflections on every single beat, including those where there are missing QRSs. There's no QRS here, and yet there's a His bundle deflection that falls on time. That suggests that during this tachycardia, the block to the ventricles occurs below the level of the His bundle, or at least in the location of the His bundle that we're able to record from this catheter, and that still could be AV node reentry, which is in fact what this ended up being. This is a 2-to-1 conduction during AV-NRT. Could this be an atrial tachycardia? Let's look at the earliest atrial activation in CS56 or 78, which again could involve a leftward extension of the AV node that isn't too far leftward for the AV node to be the mechanism, but it of course could also be an atrial tachycardia because atrial tachycardia can come from anywhere. And here's another patient in tachycardia, and in this case we're back to seeing a 1-to-1 AV relationship. Here on the surface are the QRSs, and here are the atrial intracardiac, so 1-to-1, so we can't rule out AV-RT. And let's look at the atrial electrograms and which is the earliest atrial activation site. Here it's somewhere near the septum in 7-8 or 9-10. So let's think about that activation sequence and whether that has any implications for crossing off the list any of the 3 mechanisms. Could this atrial activation be consistent with atrial tachycardia? Yes, it could. Atrial tachycardia can come from anywhere, including the septum. Could this be AV node reentry with this activation sequence? Yes, it could. The earliest atrial activation is near anatomically where the AV node is located. Could this be AV-RT from this atrial activation? Yes, it could. You could have a septal accessory pathway or something just barely off the septum. So unfortunately, we can't cross anything off the list simply from the atrial activation sequence in this example, and we have to think of other ways to distinguish one mechanism from another. Here's yet another patient who similarly has activation that is earliest near the septum. Looks like CS 910 is the earliest here. So once again, this could be atrial tachycardia or AV node reentry or AVRT. So we have to start looking at other features of the tachycardia to maybe cross off the list one or two of the mechanisms if possible. Let's think about the VA time. We talked about VA relationship in terms of one-to-one or non-one-to-one relationship, but let's think for a moment about the timing. And here we're measuring the beginning of the QRS to the earliest visible atrial electrogram. And in this example, the VA time is 50 milliseconds. What does that mean in terms of the three mechanisms? Could all three mechanisms have a VA relationship that's this close temporally? Let's think about AVRT. Here's again that AVRT activation sequence where we're going down the His-Purkinje system, across ventricular muscle, up the accessory pathway, across atrial tissue, and back down to the AV node. But when you think about the VA time, again, the V starts at the ends of the Purkinje fibers where the QRS is initiated, and then you cross ventricular muscle, and then you go up the accessory pathway. And so that has to take a certain period of time from the beginning of the QRS to the beginning of the atrial activity. What about AV-NRT? What does the AV relationship look like during AV-NRT? Well, it's a slightly different relationship that we see. Here's the circuit in the center of the heart, and what happens as this circuit spins round is that while you're going retrograde up the fast component of the AV node in the typical way that AV-NRT works, at the same time you're going forward down the His-Purkinje system to generate a QRS. So these two things are happening at the same time. So your VA time is not a sequential, but rather a simultaneous series of events, or near simultaneous. So your VA time, you'd think, in the classic AV-NRT form, we're going to review when AV-NRT goes around the other direction later, but in the classic AV-NRT form, your VA time is going to be short, and the AVRT might be a little bit longer, but the question is, are there absolute cutoffs that can help you distinguish AV-NRT from AVRT? And the answer, of course, here is yes. Here's a manuscript from 1979 that looked at the shortest VA interval during different types of SVT, reentrant SVT, including looking at AV-NRT, AVRT with a concealed accessory pathway that only conducts retrograde, and patients with AVRT and overt WPW where their pathway conducted in both directions. And they found, as you can see in the graph here, looking at the minimum VA interval during tachycardia, that there was a clustering of shorter VA intervals in AV-NRT with some long ones. Those are, by the way, AV-NRT going around in the opposite direction. But notice that the AVRT had a minimum VA interval that was necessary for the Purkinje fiber to conduct across ventricular muscle and up the accessory pathway. And so what did they find was the minimum interval? They found that if they looked at all patients with accessory pathways, both overt and concealed, a VA time less than 70 milliseconds was never recorded during SVT. So that 70 millisecond cutoff is an absolute. They started to put their statistician hat on after that, and they said, well, if you want to think about two standard deviations here, you could actually use a number of 61 milliseconds if you wanted to be really, really sure, because there were a couple of intervals that really were very close to 70 milliseconds. So if you wanted to be even more confident that this VA time being shorter than 61 milliseconds was highly unlikely to represent AVRT, you could use that shorter number. But really 70 milliseconds is the standard cutoff that people use to rule out AVRT if you see a VA time shorter than that. So back to our tachycardia here, this VA time can allow us to cross off AVRT because 50 milliseconds is shorter than 70 and shorter than 61 milliseconds. So we can be quite confident that there's no way there was enough time, if this had been AVRT, for you to get from the beginning of the QRS back up to the atrium this quickly. And so that's very helpful. Even while the activation sequence was not, the timing is. I had mentioned earlier that spontaneous tachycardia termination could represent an opportunity to clarify tachycardia mechanism. At first, you might think when you see a tachycardia that you had just induced terminate, you might think, oh shoot, it terminated, I need to go initiate it again so that I can analyze it and do maneuvers. But before you do that, go back and look and see exactly how it terminated, because there might be useful information there, such as in this case. Here we have a 1-to-1 SVT going on, where you have a spontaneous termination, and the last event is an atrial event. Why does that matter, and what does it signify? Let's think of the 3 tachycardia mechanisms and how each of them might spontaneously terminate. AV node reentry, of course, that's a circuit within the AV node that goes down the slow component of the AV node and retrograde up the fast and down the slow, and up the fast and down the slow down to the ventricles and back up the fast to the atrium, and then that might block forward in the slow component of the AV node. Is that a feasible, plausible explanation? Yes. The AV node could have an alteration in its refractory period and spontaneously terminate, not unreasonable. What about AV-RT, where you'd be going down the AV node and up the pathway and down the node and up the pathway and down the node and up the pathway? Could it block forward in the AV node? Yes, the AV node in these reentrant tachycardias is often the weakest link, and whether it's a change in autonomic influence on the AV node or whatever it is that may subtly change the refractory period, blocking in the AV node in the forward or the backward direction is a very plausible tachycardia termination mechanism. But let's think for a moment about atrial tachycardia. If this were an atrial tachycardia, then you'd have this P wave conducting to this QRS and this ATAC beat conducting to this QRS, and then this is the last ATAC beat, and then it stops. But why did this last atrial event not also conduct forward to the ventricles? It comes at exactly the same cycle length as the preceding ones, and there's no reason why, if this spontaneously terminated, why would that last atrial event not also conduct down to the ventricles? Now, if this were a PAC that terminated and it blocked because of a shorter cycle length or an alternate focus, then fine, you have a mechanism for termination that isn't really spontaneous termination, it's sort of an ectopic beat that terminated. But that's not what happened here. It's the same activation sequence at the same timing. So the chances that this is an atrial tachycardia are exceedingly unlikely. Now, how would you explain this phenomenon in simple terms? And here's really what you'd have to say in order to explain why this observation of terminating with an A would not likely be an atrial tachycardia. You'd have to say, in the absence of adenosine administration, now remember, if you gave adenosine, you could have different effects on the heart at the same time, so you could actually terminate an ATAC and cause AV node block at the same time. But you'd have to describe this phenomenon by saying, in the absence of adenosine administration, which could result in simultaneous electrical effects, it would be a remarkable coincidence that at the moment of spontaneous termination of an atrial tachycardia, without a premature or alternate focus atrial complex, the very last beat for no reason happened to also fail to conduct to the ventricles. And the improbability of that unique coincidence makes this very unlikely to be an atrial tachycardia. That's how you would explain this phenomenon. But now I'm going to induct you into the club of EP, where we have a code, where we can summarize this statement in short form, and we all know what each other's talking about in this club. Now officially, each of you can say, it ends with an A, wink. And what we mean by that is that this is very unlikely to be an atrial tachycardia. So you see this observation, you can cross ATAC off the list. One other, by the way, interesting thing that's seen on this slide, because you should look at everything on every slide, is that on that last sinus beat, there's another little finding. There's a delta wave, there's a short HV interval, and so you might think to yourself, oh, maybe this is AVRT. And you would have, of course, discovered this in the first part of your EP study, where you made observations in sinus rhythm, where you did pacing and you looked at the HV and you brought out more pre-excitation. So this is not a new finding. Presumably with tachycardia termination, you would have seen this during sinus rhythm. But remember, of course, you could have AV node reentry even in the presence of an accessory pathway, but use all the information that you have. And here's another example of a spontaneous termination of SVT. You have a 1-to-1 AV relationship. And the question here again is, did this end with an A or a V? Because if it ended with an A, that would be helpful. Here's the last atrial event. And your first instinct might be, oh, this ends with a V, right? Because the QRS here is after the atrial event. But think again for a moment. If this were an atrial tachycardia, for example, then would this A lead to this V? The answer is no, that's impossible. Here's the His bundle recording. This A would have had to travel back in time to get above the His and then travel forward to this His and this V. So in fact, this V, this ventricular event, is generated from this A if this were an ATAC, in which case this A would go to nothing. So this actually is also ending with an A, even though the atrial event here is buried within the QRS and the QRS hangs past the atrial event, but still this technically is ending with an A. So if we put our checklist up, we can cross off atrial tachycardia for exactly the same reason that we crossed it off on the previous example. It ends with an A without this A being early. This isn't a PAC or something that is terminating an ATAC by coming in early. This is right on time and then terminating. And then why don't we think about the other lessons that we've learned and look, for example, at the VA time. Here, the beginning of the QRS to the earliest atrial electrogram is 0, which is less than 70 milliseconds. So we can actually, in this case, also cross off AVRT. Poof! Even though this was a spontaneous termination, we got it going, it stopped on its own. You might think, oh shoot, I need to get it reinduced so that I can figure out what it is. You actually have the entire diagnosis here from spontaneous termination with an A and the observation that the VA time is ultra short. This is AVNRT, done. You can certainly induce and do other maneuvers just to verify, but you have the entire diagnosis. So again, don't ignore spontaneous terminations because there can be a wealth of information there. Here's the onset of another SVT that was initiated with atrial burst pacing. We can see the pacing artifact in the HRA catheter. We can see the stimulation channel telling us that we had a series of S1s, and here are the last two paced beats. And here we are off into SVT with a 1-to-1 AV relationship. But notice that there is actually some variability in the cycle length, the intervals between the atrial events and the QRSs. And let's see if that variability is helpful in ruling out any of the tachycardia mechanisms. Here I've first measured the His or HH intervals in the beats during the onset of tachycardia. And this variability we sometimes call wobble or cycle length variation, and it is something that can be actually very helpful, again, during spontaneous changes that can occur in a tachycardia. Here I've measured the AA intervals in green, and notice here how the changes in cycle length first appear in the His intervals and then appear in the AA intervals. These HH changes precede the AA changes. Is that helpful? Yes, it is. This directly suggests that atrial tachycardia is very unlikely, because if the atrium was in charge, then if there were changes in the tachycardia cycle length, you would first see them in the atrial activity, not in the His activity. So you can actually rule out atrial tachycardia as a mechanism here when you see cycle length wobble. If the HHs precede the AAs in a reliable way, then you can cross off atrial tachycardia, because again, the A's are not running the show. You can see this in AVNRT, you can see this in AVRT. And another term that sometimes people call when they see the H's or the V's driving the A's is VA linking. I don't like this term that much. What it means to suggest is that there is a fixed linking cycle length, or interval I should say, between the beginning of the QRS and the atrial events. The A's are sort of linked to the preceding ventricular events. The reason I don't like the term is linking is used to mean other things in EP as well, and so to avoid confusion using the word linking to refer to two different EP phenomena, I tend to not use it in this particular scenario. Instead, you can say something like the A's follow the V's, or there's a fixed VA time is another way to say it. All of these imply the same thing, which is that the A's are not running the show, they're following, and therefore this is not an atrial tachycardia. Having now made observations during the tachycardia itself, including the AV relationship, the VA timing, the earliest atrial activation, the spontaneous termination observations or cycle length wobble, you may have been able to cross off one of the three diagnoses from the list, and occasionally maybe even two. But there are some scenarios that we reviewed where we only crossed off one thing and we're still left with two. And so that's where maneuvers come into play. There are so many things that you can do to manipulate the tachycardia that can help you rule out that remaining diagnosis. Or actually, there are scenarios you may not be able to cross any of the three things off the list from spontaneous observations, in which case you definitely need to do maneuvers in order to figure out what is the diagnosis. So let's talk about ventricular pacing maneuvers that can be done during SVT, which can be extremely helpful and solidify and finalize your diagnosis. Here's an example of an SVT where we have a one-to-one AV relationship. The cycle length of the SVT is 275 milliseconds. And let's use the things that we've already learned. Here's the VA time is 16 milliseconds. So why don't we cross off the list AVRT? It's less than 70 milliseconds. So this is impossible for this to be AVRT. Wonderful. But again, we're left with two possibilities. This could be AV node reentry, where you're going up to the A and down to the V nearly simultaneously. We talked about that during the AV NRT circuit, but it also could be an atrial tachycardia. How can you have an atrial tachycardia with an A on top of the V? Well, of course, as I said earlier, it isn't that this A is conducting to this V. That's impossible to go back in time, but this A would conduct to the next V, and this A would conduct to the next V. So this absolutely can be atrial tachycardia with an ultra short VA time because of that relationship. So we need to do something else to distinguish atrial tachycardia from AV node reentry in order to make a definite diagnosis. One of the most powerful things that we can do in manipulating an SVT is to do ventricular overdrive pacing. Pacing in the ventricle a little bit faster than the tachycardia, only a little bit, so that we don't terminate it, but that we take over the tachycardia, we stop pacing, and we see what happens. And let me show you why this maneuver is so powerful and helpful in the various types of tachycardias to rule in or rule out a certain diagnosis. Here's what would happen in an AVRT circuit if you took over the tachycardia with ventricular pacing. You'd put a catheter in the right ventricle, typically on the septum or near the RV apex, and you start pacing. And by the way, if you're not familiar with entrainment or overdrive pacing, feel free to refer back to my entrainment video, which talks about reentry and pacing a little bit faster than reentry in order to take over the circuit, and that will give you this concept in a little more detail. But here we are with a ventricular catheter pacing, and here's what happens if you don't terminate the tachycardia, but you take it over with ventricular pacing a little bit faster. You pace in the V, and you conduct retrograde up the accessory pathway in exactly the same way that was occurring during the tachycardia itself. Again, this is AVRT as an example. And on that last paced beat, before you stop pacing, the last two things that happen on the last paced beat are you have a ventricular event, that's the pacing. You conduct back up to the atrium, back up the accessory pathway in the same way as during tachycardia. And what is the next spontaneous thing that would happen if you didn't terminate tachycardia? Well, what would happen is it would turn around and come right back down the AV node in His-Purkinje system and create another V. And so we would refer to this as a VAV response. The VA is the last paced beat, and the yellow V is the first spontaneous thing that happens after termination of pacing. That's what happens in AVRT. What about AVNRT? Here's your circuit that's ongoing within the AV node. Here's our catheter, and we're going to take over pacing. So we pace a little faster, and every time we pace, it goes retrograde up, in this case, the fast component of the AV node, just like during tachycardia, because we took over the circuit in the same way that it was traveling during tachycardia. And then again, the last two events that happen on that last paced beat are you have a ventricular event and an atrial event, and then we stop pacing. And what's the next thing that happens if we didn't terminate the tachycardia? It comes right back down the slow component of the AV node back down to the V. And again, we have a VAV response in AV and RT. So notice this VAV pattern is seen in both AVRT and AVNRT, and so that sequence is not helpful to distinguish one from the other. However, in an atrial tachycardia example, something different happens. Here's an atrial tachycardia where you have a firing spot with each A conducting down to the ventricles. Here is our ventricular catheter, and we start pacing a little bit faster, and we have retrograde conduction that suppresses the atrial tachycardia. And so here we have a series of pacing pulses, and if we don't terminate the tachycardia, the last paced beat again will give us a V and an A as we capture the ventricle and travel retrograde up to the A. But now, when we stop pacing and we wait for spontaneous things to occur during an ATAC, what's the next thing that happens? The next thing that happens is your atrial tachycardia fires and then travels back down to the V. So here you have a VA with pacing in green, and then AV response during the spontaneous resumption of tachycardia that had not been terminated. And so that's different from what you see during the two reentrant forms of SVT. And here is one of the most important papers in all of SVT diagnosis describing this maneuver, published by Dr. Brad Knight in 1999. And here's the most important part of the central table in this manuscript, looking at the distinction between AV and RT, or ORT, which of course is also known as AVRT, looking at this maneuver and the response that you see when you overdrive pace and stop pacing. In these two reentry mechanisms, you see 100% of the time a VAV response. And if you have atrial tachycardia, 100% of the time you see a VAAV response. How powerful is that? That you do overdrive pacing and you stop pacing, and you have incredible sensitivity and specificity to distinguish an atrial tachycardia from the two reentry forms of SVT. This is one of the central maneuvers that you will use in every single SVT EP study to rule in or rule out an atrial tachycardia. So let's go back to this case where we already crossed off AVRT because of the ultra short VA time, but we were unable to distinguish atrial tach from AV and RT. Here we do overdrive pacing. The tachycardia itself was 270 milliseconds in cycle length. We paced in the ventricle at 260 milliseconds and did not terminate the tachycardia. We look and make sure that we conducted retrograde back up to the A, and sure enough, we advanced atrial activity, so that here is the last advanced atrial event, and let's analyze it. We have on the last paced beat V going back up to A, and then what is the next spontaneous thing to occur? Here, the A and V are somewhat simultaneous, so in fact, I'm going to draw lines here. Yellow is where the His is inscribed, purple is where the earliest ventricular event is located, the beginning of the QRS, and the green line is the earliest atrial event, which is here in the coronary sinus. So you might say, I don't know which is the next thing, V or A, but remember the His bundle counts as a V because we're going back down to the ventricle, hitting the His bundle first. So sometimes people refer to this as a VAH or VA-His response, but that truly is equivalent to a VAV response. So in fact, in this case, with a VAV response, we can rule out atrial tachycardia as the mechanism and cross that off the list. And we have now made the diagnosis of AV and RT by a spontaneous observation of a short VA time. And with our ventricular overdrive pacing maneuver, where we have a VAV response ruling out atrial tachycardia, and there we have the definite diagnosis of this tachycardia mechanism. But there's even more information that you can get when you do a ventricular overdrive pacing maneuver that can help you distinguish AVRT from AVNRT. It isn't in the VAV response, which is common to both, but let's have another look at this maneuver and think about it from an entrainment standpoint. And again, reviewing the entrainment video that I've put out and talking about the post-pacing interval will be very helpful for understanding this concept, which I'm going to review. Here, once again, is the AVRT circuit, and here is roughly the location of where you'd expect to pace, sort of in the apical or on the RV septum. And notice how close or far we are from this reentry circuit. Let's say it's a left-sided pathway and we're pacing on the right side of the septum. We're certainly not in the circuit when it's AVRT, but we're not far from it from this pacing site. So when we entrain and we look at the post-pacing interval, which, as you recall from my other video, is going to include the time it takes to get to the circuit, the time it takes to get round the circuit, and then the time it takes to get back to that same electrode from which you paced on that last paced event. That's the post-pacing interval. It's going to be probably not the same as the tachycardia cycle length because you're not in the circuit, but you're not far from it. So that post-pacing interval will not be that much longer than the tachycardia cycle length. In contrast with AV-NRT, the circuit is way up here in the AV node, and we're pacing down here in the septum or typically toward the apex. And so in this case, you're really far from the circuit. And so your post-pacing interval, if you entrain without terminating the tachycardia and then you stop pacing and you look at that first interval in the pacing electrode, it's going to be much longer than the tachycardia cycle length. So the question is there a way, is there a cutoff number that can help distinguish how close or far you are from the circuit to look at the difference between the AVRT scenario and the AV-NRT scenario? And of course, there is another one of the seminal principles in EP study evaluation for SVT. This is published by Dr. Greg Michaud in 2001, and they looked at the post-pacing interval minus tachycardia cycle length, and in this case, they described the maneuver as pacing in the RV in the apex or on the septum at a cycle length 10 to 40 milliseconds shorter than the tachycardia itself, again, to try to avoid altering the circuit or certainly not terminating the circuit as you pace. And they looked at specifically AV-NRT from septal ORT or AVRT. Remember, if you have an eccentric activation sequence, a lateral accessory pathway way over on the right or way over on the left, you don't really need these maneuvers to help distinguish from AV-NRT because the eccentric atrial activation itself can rule out AV-NRT. So a lot of these maneuvers are designed to distinguish AV-NRT from AVRT when you have a septal pathway, when you have a concentric activation of the atrium during tachycardia. And in this comparison of AVRT versus AV-NRT, they noticed a very distinct clustering of post-pacing interval minus tachycardia cycle length that was shorter in the AVRT scenario because you're much closer to the circuit, and much longer in the AV-NRT scenario because you are much further from the circuit. And a cutoff of 115 milliseconds seemed to very clearly delineate one from the other. So let's go back actually to the same tachycardia that we looked at before, which we knew was AV-NRT from the VA time being short and from the VAV response. But let's think about it from the post-pacing interval perspective and see if that finding is consistent with AV-NRT as well. So here we have the tachycardia cycle length, and here we have the post-pacing interval from the pacing location, which was that RV apical septal catheter, and measuring from the last paced beat to the first electrogram in that same electrode pair gives us a measurement of 430 milliseconds. And if we look at that difference, the post-pacing interval here from the tachycardia cycle length, we get 155 milliseconds, which is significantly longer than that 115 millisecond cutoff. So this is also now consistent with AV-NRT. It's important to look at all the features of your maneuvers and make sure that they are all consistent with the same diagnosis, because if you have a contradiction or a conflict, you need to resolve that conflict before you ablate to make sure that you're ablating the right thing. Here's another scenario where we did ventricular overdrive pacing, and here is a one-to-one tachycardia that we see at the right half of the screen with a long VA time, and here we have the last 3 beats of ventricular overdrive pacing, a little bit faster than the tachycardia. Let's just look at for a moment the SVT itself and see if we can use anything to distinguish and cross off anything off the list from the three mechanisms. The earliest atrial activation looks like it's CS56. You know, that's a little bit eccentric, but it depends on where your coronary sinus catheter is positioned. And is it possible to have a left inferior extension of the AV node that extends out this far to activate the atrium at the CS56 location? Yeah, it's possible. So I wouldn't fully cross off the list AV node reentry from the activation sequence. What about the VA time? It's 140 milliseconds. Is that short enough to rule out anything? No, it is not. It's longer than 70. So this is one of those findings that if you were to see it, meaning less than 70 millisecond VA time, it's helpful. But if you don't see it, it isn't helpful. You can't cross anything off the list in the reverse scenario. So unfortunately here, the VA time is not fully helpful, and the earliest atrial activation isn't fully helpful. And of course, this could be an atrial tachycardia as well. Atrial tachycardia can come from anywhere, including near CS56, and that wouldn't be an abnormal PR interval during ATAC. So we haven't ruled out any of the mechanisms of tachycardia from the VA time or the atrial activation sequence. So let's see if ventricular overdrive pacing helps. Here's the cycle length of the tachycardia, 350 milliseconds. And here is our pacing rate, 330 milliseconds, 20 milliseconds faster. And we look and make sure that we, in fact, advanced the A, very important to analyzing this maneuver. Here is the last advanced A that was advanced to the tachycardia pacing cycle length. And so let's first think about the response after we come off pacing in terms of atrial and ventricular events. We have a VA on that last paced beat. What's the next thing to happen? It's a V. So because we have a VAV response, we can now rule out atrial tachycardia and cross it off the list. Wonderful. One thing down. And let's now think about that post-pacing interval minus tachycardia cycle length comparison. Here's the post-pacing interval from the pacing location on the RV apical septum, the last paced beat to the first electrogram in that same electrode pair. It's 425 milliseconds. And as we do this math, the post-pacing interval minus the tachycardia cycle length, in this case, is 75 milliseconds, shorter than that 115 millisecond cutoff. That would be consistent with AV-RT, so we can cross AV-NRT off the list because we're pretty close to the circuit, although of course not right in it. So we've made the entire diagnosis with this ventricular overdrive pacing maneuver, looking at the VAV response and looking at the post-pacing interval in the right ventricular catheter. Here's another SVT. Let's see if ventricular overdrive pacing can be helpful here. Let's first look at spontaneous observations before we do any manipulation. What is the earliest atrial activation? There's a far-field atrial signal in the His catheter, so this is a concentric or central activation. Is that helpful? Can that rule out any of the three mechanisms? Can an atrial tachycardia come from here? Yes, sure it can, so you cannot cross that off. Could this be seen in AV-NRT, early activation at the His level? Of course it can. That's right near where the AV node sits. Could this be AV-RT, where you activate the atrium on the septum? Of course it could. You could have a septal or Para-Hisian pathway that conducts retrograde right near that His bundle. So unfortunately, we can't cross off any of these from the list because of the atrial activation sequence. And likewise with the timing, the VA timing is not ultra short, so we can't cross off AV-RT, for example. So unfortunately, spontaneous observations are not helpful to eliminate any of the tachycardia mechanisms. So let's do ventricular overdrive pacing and see if that's helpful. Here's that same tachycardia where the cycle length was on the long side, 465 milliseconds. So we chose to pace a little bit faster at 450 milliseconds. And here we've demonstrated the last advanced atrial beat. So let's think about the ventricular overdrive response. When we come off pacing, we have a VA sequence, of course, on the last pace beat. And then what's the next thing to happen? It's an A. So here we have a VA-AV response. We can cross off the list the AV-NRT and AV-RT options. We've now made with this one maneuver the diagnosis of atrial tachycardia. This happened to be a Para-Hisian atrial tachycardia, so you have to be very careful when you ablate because you want to, of course, not damage the AV node or the His bundle, and this atrial tachycardia focus was close to both. It was successfully ablated. Here's yet another tachycardia where we first look at the cycle length, which is 375 milliseconds. It's a 1-to-1 AV relationship. We look at the earliest atrial activation, and it looks like it is central or concentric, with earliest activation near the septum. So can this rule out any of the three mechanisms? No, it cannot. It could be an ATAC from the septum. It could be AV-NRT near the AV node. It could be AV-RT with a pathway that is septal. So unfortunately, that's not helpful. And what about the VA time? Nope, it's long, so we can't cross off anything off the list. It could be any of the three mechanisms. And by the way, this can be AV-NRT. We talked earlier about how the typical form of AV node reentry involves an ultra short VA time. That's because the normal way that AV-NRT goes is forward down the slow and retrograde up the fast, so the VA time is quick. However, you can have AV-NRT go in the opposite direction, and it can go down the fast and up the slow and have a long VA time. So this absolutely could be the uncommon or the atypical form of AV-NRT. You cannot rule that out because of the long VA time. So unfortunately, from spontaneous observations, we cannot cross off any of these three mechanisms from the list. So let's do ventricular overdrive pacing and see if that's helpful. So here we have the tachycardia cycle length. It's right now about 380 milliseconds. Notice it can change a little bit from moment to moment, so always measure it right before you come on pacing to make sure you pick an appropriate pacing rate. Here we ended up choosing a pacing rate maybe a little bit faster than we needed to, 340 milliseconds, but within the parameters that all the studies of these mechanisms used. So we paced at 340, and sure enough, we accelerated the atrial rate to 340 milliseconds. And so on first glance, we say, okay, we have a VA-AV response, right? So we can say, aha, it's an atrial tachycardia. But wait a minute, not so fast. We forgot to make two more measurements. We need to figure out not only did we accelerate the atrial rate to the pacing rate, but we forgot to figure out which was the last advanced atrial event, because here's another fake out. If you made further measurements in the AA intervals, you would see that in fact there was one more interval that was accelerated to the pacing rate. This last paced ventricular event conducted not up to this atrial event, but to this atrial event. It's a very long VA time. And so when you analyze this response after ventricular overdrive pacing, we need to take that into account. So your VA sequence on the last pace beat is this. It isn't to this one. So that changes everything, of course, in how you interpret the response. This is a VAV response, not a VAAV. It's a pseudo VAAV response. So always measure every interval to figure out which is the last advanced A and which is the next A that falls back to the tachycardia cycle length. So now this is a VAV response. We can cross off atrial tachycardia from the list. And then let's think about the post-pacing interval measurement and see if that's helpful to distinguish AV node reentry from AV-RT. Here is the post-pacing interval. It's quite long, 560 milliseconds. So if we do this calculation, 560 minus the tachycardia cycle length, 380, is 180 milliseconds, significantly longer than that 115 millisecond cutoff. So here we can cross off AV-RT, and from this one maneuver, we've now made the diagnosis of AV-NRT. And again, in this case, it is the uncommon form or the atypical form of AV-NRT with a long VA interval because you're going up the slow and down the fast. But nonetheless, with this one maneuver, this still works, and we've been able to rule out two of the three mechanisms and definitively make the diagnosis of AV node reentry, and you can proceed with ablation. I just wanted to highlight one more time this the terminology and the sequence of what happens in this form of AV and RT. Notice again that the forward direction of AV and RT is going down the fast component of the AV node, giving you a short PR interval, and the retrograde is going up the slow, giving you a long VA interval. And the terminology that people will refer to this include atypical AV and RT, or the uncommon form of AV and RT, but people will also call this fast, slow AV and RT, referring to the sequence of going forward down the fast and up the slow, as opposed to the more common form of AV and RT, the slow, fast form of AV and RT, where you normally go down the slow in the forward direction, just to clarify that terminology in case you hear it. The last category of observations that I wanted to review in this SVT presentation has to do with the anatomy of each tachycardia mechanism. Sometimes you get really lucky and you can see either a spontaneous occurrence or an observation made during a pacing maneuver or a manipulation of the tachycardia that gives you a really strong clue to either rule out a diagnosis or sometimes even rule in a diagnosis, meaning you could rule out 2 of the 3 and make the diagnosis with a single observation. And these findings have to do with the anatomy of the tachycardia itself, and I'll show you what I mean. When you think about the anatomic structures that are necessary for each SVT mechanism to perpetuate, there are clear differences between the 3. And here's what I mean. For atrial tachycardia, all you need is atrial tissue for the tachycardia to be ongoing. In fact, all you need is the local atrial tissue of the focus itself, or the very small circuit, if that's the mechanism. You could even cut out that local atrial tissue and put it in a dish, and it would continue to fire and have ongoing tachycardia because it would be unaware that the rest of the atrium wasn't there. It doesn't need the rest of the atrial tissue or the conduction system or the ventricular muscle for the tachycardia to perpetuate. With AV and RT, you need the AV node, of course. There's a whole family of AV and RT circuits, some of which involve actually atrial tissue nearby, but some don't. And so, for example, in the latter, if you cut out the AV node and put it in a dish, it could continue that circuit if the entirety of the circuit is encompassed in that tissue. So if you were missing the atria, or missing the His-Purkinje system, or missing the ventricles, then the tachycardia could continue. Again, you could put it in a dish and it wouldn't know any differently. In the versions of AV and RT that require atrial tissue, then you would need to have the atria involved. But almost no AV and RT that I know of involves the structures below it, so you couldn't have them present during the tachycardia, and the tachycardia could perpetuate. AV-RT is somewhat unique in that, as we've discussed before, you really require all of the different components of the conduction system in order for it to perpetuate. And I mean, you need the AV node, you need the His bundle, you need at least one bundle branch, you need ventricular muscle, you need an accessory pathway, and you need atrial tissue. So you couldn't remove any component of this and have the tachycardia continue. So why does this matter? What do the anatomic structures mean in terms of observations made in the EP lab? Well, if you had an SVT that was ongoing and you were missing a ventricular beat, but the atrial rhythm kept going at exactly the same cycle length, which of these could you rule in or rule out? Well, do you need the V for an AT? No. So you're missing a V, you could easily be an atrial tachycardia. What about AV and RT? If you're missing ventricular beats, could it be AV and RT? It still could, absolutely. What about AV-RT? And we've reviewed this already. No, it could not. So if you're missing a ventricular beat, AV-RT is absolutely ruled out because ventricular tissue is part of the circuit and necessary. What about a missing atrial event? Could you have an atrial tach if the V's kept going and you're missing an A or more? No, it couldn't. You need the A for every single beat. That's essential to the tachycardia. What about AV and RT? As I said, there are versions of AV and RT where you could be missing atrial events with ventricular events continuing, and it could be AV and RT for some of those in that family. What about AV-RT? Just like if you're missing a V, it can't be AV-RT. Likewise, if you're missing an A, it cannot be AV-RT because AV-RT necessarily involves going across atrial tissue as part of the circuit. What about if there's AV node block? If you give adenosine and you cause AV block and suddenly you're missing ventricular events because you've blocked the AV node completely. Could this be Atrial tachycardia, if the tachycardia is ongoing? Yes, it could. You don't need the AV node for AT. What about AV and RT? It could not. If you blocked the AV node completely with adenosine, AV and RT could not perpetuate. And the same with AV-RT. The AV node is part of that circuit as well. So it's important to think of what structures are essential so that when you make observations that a structure is shown to either not be required that has implications, or a structure absolutely must be required that also has implications. And let's review some examples. We've reviewed this before, but here's yet another example. Here's a tachycardia that has more atrial events than ventricular events, and you can see there's a missing V near the beginning and near the end of this tracing. And as we've discussed before, I don't mean to belabor it, that absolutely rules out AV-RT. It still could be atrial tachycardia, and you can also have AV-RT that fails to conduct forward to the ventricles and still perpetuate, and you have missing Vs, usually in a 2-to-1 pattern, but sometimes occasionally you can have more unusual patterns, although that's much less common. What about this scenario where you have an ongoing tachycardia, but you're missing atrial events? Which of the three could this be, or which things are ruled out? Well, we discussed this in that anatomy slide. This absolutely cannot be an ATAC if there are absent atrial events, and it cannot be AV-RT. So the only one of these three it could be is AV node reentry. We didn't get into it in this presentation so much, but this could be a junctional tachycardia, and there are maneuvers that can be used to differentiate AV and RT from junctional tach. This was AV and RT that happened to be missing some atrial events, and we were easily able to rule out 2 of the 3 possibilities and moved forward toward the diagnosis because of this spontaneous observation. Here's a tachycardia where adenosine was given. The tachycardia did not stop, as you can see, from ongoing atrial events, but the ventricular events disappeared. And again, thinking about which of the tachycardias can continue in the setting of complete block of the AV node, actually only one of the 3. This would make the diagnosis. AV and RT cannot happen if you block the AV node because it's essential and in fact is the entirety of the circuit, and AV-RT could not happen because it requires the AV node as well. And I'm talking, of course, about orthodromic AV-RT. There are exceptions, of course. You could have an unusual form of AV-RT that involves 2 different accessory pathways going up one pathway and down another, but that, of course, would not be a narrow complex tachycardia because you'd be activating the ventricles forward over an accessory pathway, and you would get a very wide, bizarre QRS in that scenario. And here's a classic example that you're going to see on board exams because it's such a cool observation when you see this spontaneous occurrence during tachycardia. Look at the tachycardia change in its QRS morphology. We can see over here to the left you have a wide complex QRS in a left bundle branch block pattern, and then it switches to narrow. But not only mid-tachycardia does the QRS width and morphology change, but on top of that, in this example, the cycle length changes as well. On the left, you have a longer cycle length, which means that it's slower at 167 beats per minute. And as the tachycardia QRS narrows, the tachycardia accelerates up to 188 beats per minute or 320 millisecond cycle length. So what does this mean? It's certainly possible, I suppose, you could have 2 different tachycardias, one switching into the other, but that would be unusual, and there's actually a more elegant explanation when you see this, a bundle branch block that either appears or disappears, creating a narrow QRS or having it disappear. What are the implications when you see this and there is an impact on the cycle length of the tachycardia? Let's think for a moment about the various tachycardia mechanisms and whether a bundle branch block should impact the rate or the cycle length of that tachycardia. Here's an atrial tachycardia firing away, and let's say mid-tachycardia you get a left bundle branch block. Would the ATAC know about that? Would it change its rate? Absolutely not. So a bundle branch block should not have any impact on the cycle length of an AT. What about AV and RT that's going round and round in the AV node? And you have a bundle branch block appear during that. Would the tachycardia have any awareness that the bundle branch block had occurred? No, it would not. So you should likewise not have any impact on the cycle length of the tachycardia during AV nRT in the presence or absence of a bundle branch block. What about AVRT, where you have this circuit, and let's say you develop a left bundle branch block with this left-sided pathway? Would that impact the circuit? In this case, yes, it would. You'd still have AV nRT, but you'd have to go down the contralateral bundle in order to get into ventricular muscle and then back up to the accessory pathway. What does this mean in terms of the tachycardia cycle length? Well, look at the circuit. It's actually significantly longer. And another observation, which actually becomes more important as I'll review, is that the time between the onset of the QRS and the time it takes to get to the atrial tissue will prolong in this situation where you have a bundle branch block on the same side as the accessory pathway, that's the retrograde limb. Because in this case, when you initially, without the bundle branch block, activated ventricular tissue, it's the shortest route that's going to be followed. So the closest Purkinje fiber to the pathway is going to be responsible for getting the signal up to the pathway the fastest. And if you developed that bundle branch block, you can again still get to ventricular muscle, but it's further away from the pathway. So the start of the QRS to the time it takes to traverse all that myocardium, that extra myocardium, and get back up to the A is going to be longer. So here you would in fact impact the cycle length of the tachycardia in this scenario if you had an ipsilateral bundle branch block. There's an asterisk there that I'm going to review in a moment. What about if you had a contralateral pathway and a contralateral bundle branch block? In this case, a right-sided pathway, but a left bundle branch block. Actually, it should not impact the cycle length or the VA time in this scenario because the closest Purkinje fiber is not in the bundle branch that was blocked. So you can have AVRT occur with a bundle branch block appearing or disappearing without any impact on the tachycardia, but that would suggest that the bundle branch block may be further away on the opposite side of where the accessory pathway is located. So going back to this example, we see here that you have a left bundle branch block QRS, you narrow the QRS and you accelerate the tachycardia. Of the three mechanisms here, the only one that it could possibly be is AVRT. Again, AT and AV and RT should not have any awareness that the bundle branch block is occurring. And I'm showing here in the diagram that you are now transitioning, in this case, from a left bundle branch block scenario with a longer route to recovery of the left bundle branch, and now you have a shorter route, and in this case, a shorter cycle length. So getting back to that asterisk, when you are going round and round in a larger circuit and it takes longer to get from V to A, you'd think that why shouldn't that always create a longer cycle length, a slower rate? Well, it turns out when you think about the AV node component of this circuit, if you were to speed up, let's say you have a left bundle branch block and you recover it, and now you have a shorter VA time, that means that you're actually going to get up to the atrium early and you're going to hit the AV node earlier than you would have, and you can get some decrement because we know so well by now that the AV node has decremental properties. So depending on how much faster you hit it and how much decrement the AV node displays, you could compensate for the shorter amount of time it took to get back to the A with a longer amount of time that it takes to get through the AV node because of that decrement. So you may not see as dramatic, or in fact maybe not any, cycle length change when you have the disappearance of a bundle branch block or the appearance of a bundle branch block. In that latter category, okay, it took longer now to get from V to A, and then you hit the AV node later, and it may conduct better because you have less decrement in the reverse direction. So looking at the cycle length alone is not sufficient to see if a bundle branch block impacts the tachycardia, but you would see a change in the VA time, the beginning of the QRS to the earliest atrial activity. If you do see a cycle length change, it's very helpful, but if you don't, then also look at the VA time. And of course, we're going to look at that with intracardiacs. That's hard to tell here with the surface EKG, but I wanted to review that concept before we get to the intracardiacs. Oh, and of course, in addition to concluding that this is AVRT from seeing the cycle length change, we can also conclude that this is a left-sided lateral pathway because this is a left bundle branch block that affected the tachycardia cycle length. So we know not only that this is AVRT, but we also know the sidedness of the accessory pathway that must be participating. So now we're going to look at the same phenomenon with intracardiac recordings. But as you'll see, we're now going to be on the opposite side of the heart, as I'll show you. Here we have ongoing tachycardia throughout the screen, but on the left we have a narrow QRS, and on the right we develop a right bundle branch block, as you can see here in lead V1. And if you actually look at the cycle length, it actually doesn't change a whole lot from one side of the screen to the other. I didn't put calipers on it because there's a little bit of cycle length wobble, but in general there wasn't really an appreciable consistent difference in cycle length. However, if we look at the VA time during the narrow QRS portion, it's 85 milliseconds. Again, we're measuring this from the beginning of the QRS to the earliest atrial signal. And by the way, it shouldn't escape you that the earliest A is over here in the high right atrial catheter, another clue about the tachycardia mechanism here. But the VA time is consistent and shorter when the QRS is narrow, and then when we get a right bundle branch block, suddenly the atrium bumps out. Here's the beginning of the QRS, and here's the earliest A. Same activation sequence, but it just gets later. So the VA time absolutely was impacted by the development of a bundle branch block. That should not happen with atrial tachycardia or AVNRT because they would be blissfully unaware that the aberrancy had occurred. So again, when we look at our checklist and we see this phenomenon of VA time changing with the presence or absence of a bundle branch block, we can cross off ATAC and AVNRT, and we can say with this one observation that we've narrowed it down to AVRT. And in this case, because the right bundle branch block is present and impacts the tachycardia, we can also say that it's in fact a right lateral pathway that's participating retrograde in this tachycardia. Now here is an interesting finding that can also help rule out one tachycardia mechanism simply in the way that this tachycardia terminates in the setting of an early ventricular beat that we, in this case, put in on purpose with a ventricular paced beat. So here's the tachycardia ongoing. I've highlighted the atrial events, and here's this PVC beat. And when I say PVC, this is a iatrogenic PVC, if you will. It's a paced beat that we put in on purpose, and you can very specifically put in this early ventricular beat at any timing that you want. And so here we came in earlier and earlier, and this PVC resulted in termination of the tachycardia. And at first you might say, okay, how does that narrow anything down? But let's look more closely at how the tachycardia terminated. Here are the AA intervals leading up to tachycardia termination, and notice that all of the AA intervals, including the last one, are the same. They're identical. And that's important. Why is that important? Because this PVC terminated the tachycardia without advancing the atrium. Again, what does that tell us? Well, let's think for a moment about an atrial tachycardia where you have this firing spot in the atrium somewhere. If you were going to terminate that atrial tachycardia with an early ventricular beat, how would it do that? What's the mechanism? Well, you'd put in that beat, and it would have to go, in order to impact the tachycardia, retrograde up the His-Purkinje system, up the AV node, and activate the atrium early in order to get to that atrial tachycardia focus in order to suppress it. And you could terminate an atrial tachycardia with a single ventricular beat, but you'd have to pre-excite the atrium. You'd have to actually get up into the atrium to impact the atrial tachycardia because it only involves atrial tissue and no other conduction system or ventricular tissue participates. So the fact that this tachycardia ended with a PVC without advancing the atrium tells you that this cannot be an atrial tachycardia. You can cross that off your list if you see this observation. So that can be very useful. Now, could the tachycardia have terminated coincidentally as you put in this PVC and the PVC didn't cause the termination of the tachycardia? It's possible, and certainly if you had been seeing spontaneous terminations, non-sustained SVT, then it certainly could be a coincidence that you happened to put in a PVC when there was also a spontaneous termination that was not caused by your PVC. But if you had a prolonged tachycardia and it just happened to terminate right when you put in the PVC, it was sustained, that's probably not a coincidence. And certainly if you reproduce this and you do it more than once, then it's definitely not a coincidence. So that, by the way, also establishes the value so that you don't draw a conclusion that was based on a coincidence and not causal. Do the same maneuvers over and over again during SVT studies, because then you can prove to yourself that you are seeing what you're seeing and it's not purely a coincidence. Here is AV-nRT, a picture of that. Could a PVC terminate AV-nRT without pre-exciting the atrium? The answer is yes. What would that look like? Here you're pacing in the ventricle. You could get up into the AV node part way and make that part of the AV node refractory without actually getting all the way up to the atrium, and that could be enough to disrupt the circuit. So you actually can terminate AV-nRT with the PVC without getting back up to the A. And likewise, I didn't draw this, the same thing could happen with an accessory pathway. You could have an accessory pathway on one side or the other. You could get, have an early V beat and terminate the tachycardia because the pathway could be refractory at the time of that early beat, and that would be enough to terminate the tachycardia. But again, an A-tach, you'd have to pre-excite the atrium in order to terminate it. Now here is a similar phenomenon, although with a train of ventricular paced beats rather than a single ventricular paced event. So here is a tachycardia on the left, and there was an attempt here to do ventricular overdrive pacing. But unfortunately, or maybe fortunately, the tachycardia terminated during ventricular pacing, and the operator might initially think, oh shoot, I didn't mean to terminate the tachycardia. I intended to entrain it to overdrive pace it because I was looking for a VAV or VAAV response. But before you reinitiate tachycardia, go back and look and see how this terminated, because there might be some useful information there. And in this case, there is. So let's review how this terminated during ventricular pacing. So here are the atrial events during ongoing tachycardia. The cycle length of that tachycardia is 275 milliseconds, and ventricular pacing was performed, perhaps a little too fast. Remember, we said ideally you want to do it just a little bit faster than the tachycardia, maybe 10 to at most 40 milliseconds faster, but here they paced at 230 milliseconds, a little bit faster than that, and it terminated the tachycardia. But let's look at it in more detail. So here is the first missing beat. So the tachycardia terminated right around there after maybe about 4 or 5 beats of ventricular pacing. And let's look at there's one more atrial beat, by the way, over here. And this atrial beat probably is simply a retrogradely conducted atrial event just from a ventricular paced event after tachycardia had terminated. So let's see if we can draw conclusions about the tachycardia mechanism, even though we terminated it instead of doing ventricular overdrive pacing. And let's use all of the rules that we have learned so far. So let's look at the left side of the screen when tachycardia was ongoing. Let's look at the VA time. Let's not ignore that. It's ultra short, right? 15 milliseconds from the beginning of the QRS to the earliest A. What does that tell us? Well, here's our checklist. We've talked about how you can rule out AVRT if it's less than 70 milliseconds VA time. So great, we've crossed off one thing off the list. And then the next observation, we can see that the tachycardia terminated without advancing the atrium. One of these ventricular beats happened to terminate the tachycardia without pre-exciting the atrium. So we can actually also rule out atrial tachycardia. And now we've made the diagnosis of AV-nRT simply with those two observations. So don't be sad if you terminate tachycardia inadvertently. Look back and see if you can learn something, because in this case we actually made the entire diagnosis inadvertently, even though we terminated it instead of doing ventricular overdrive pacing. Here is another really cool example that is going to be seen on EP boards because it's one of those observations that actually can rule out two things at once. similar to the bundle branch block impacting the tachycardia, making the definite diagnosis. Here's another example of that type of phenomenon. So here we have tachycardia ongoing, and in this case there's a PVC. This time it happened to be spontaneous, not paced. We got a fortuitous PVC that ended up giving us an enormous amount of information. And we will look at the cycle length of the tachycardia, 355 milliseconds, and here are those atrial events. And so the first thing we can rule out, just as we've been discussing, is this PVC terminated the tachycardia without getting to the atrium, without pre-exciting the atrium. So we can rule out AT. Wonderful, one thing crossed off the list. But there's one more really important observation here. Notice the His bundle deflections where these arrows are before every narrow QRS. And if you put your calipers on those His bundle deflections and march them forward, you can see, oh my goodness, this PVC occurred right at or right after the His bundle was already inscribed. This larger arrow here shows that there is in fact on top of the PVC, kind of right at the beginning, there's still a His bundle that's exactly the same timing as the rest. So this tachycardia terminated with the PVC right after the His was activated in the forward direction, because it comes right on time. Well, why do we care that this is a His-refractory PVC that terminated the tachycardia? This is able to distinguish the other two mechanisms. How so? Think about what it means for the PVC to occur when the His bundle is refractory. What that means is that the tachycardia had activated the His bundle in the forward direction, which means that the His bundle is refractory, and that means that the back door to the AV node is closed. If you have a PVC either paced or spontaneous that occurs when the His bundle was just activated in the forward direction, you cannot possibly go backwards up that His bundle to get into the back door, get into the AV node in that route. The AV node is not accessible because the His bundle won't let you through because it was just activated in the forward direction and it's refractory. And therefore, you could not possibly have terminated AV and RT because you couldn't have had access to the AV node during a His-refractory PVC. And therefore we can rule out AV and RT. We've now made the diagnosis of AV-RT because we not only terminated the tachycardia with a ventricular event without pre-exciting the A, which rules out AT, but we also did it while the His bundle was refractory, which means we couldn't have possibly gotten into the AV node, so we can rule out AV and RT. This could only have been AV-RT. So how did it terminate the AV-RT? Well, here you had your accessory pathway, you had that early ventricular event, and it went up and it found that pathway refractory because of that early V. The pathway hadn't recovered, and that ended up resulting in tachycardia termination. A really incredible finding when you see it, whether you did it with a precisely timed paced beat or whether it happened in this case spontaneously. Now here's a corollary to that same concept, but with a train of ventricular paced beats rather than a single ventricular beat. Let me show you what I mean, because there's a lot of detail here. This is a busy image, but let's go through it methodically. We have tachycardia on the left with a narrow complex QRS and a cycle length of 320 milliseconds, and we start pacing here 30 milliseconds faster than the tachycardia, and you can see with the red arrows on top the pacing artifact on the surface EKG, and we can also see the pacing artifact in the RV apical channel, showing you that that's the location from where we're pacing. The next observation to be made is what the QRS looks like during each of the paced events. Notice that the shape of the QRS is changing here as we come on with the first paced beat coinciding with a narrow QRS. In fact, this is probably pseudo-fusion, meaning the QRS is probably not or barely at all altered compared to its narrow normal morphology. So pacing is probably not contributing to the QRS morphology, but these next two beats look different from the final three beats, meaning they're fused. What does fusion mean? It means in this case that the QRS is generated in two different ways. What are those two ways? One way shown in green is from the ventricular pacing itself, and the other shown in yellow is conducting forward down the His bundle and down at least some of the Purkinje fibers in order to also contribute to the QRS. So, and of course the amount of green versus yellow varies, and the earlier you get with the ventricular pacing, you're going to see more green and less yellow, but nonetheless the beats labeled fusion here have both green and yellow in them, and in those beats the His bundle had to have been activated in the forward direction in order for that to contribute to the QRS morphology. Okay, so who cares? Well, we care because, and I'll show you in the manuscript to follow, that if you see an observation during this transition zone, is how this manuscript describes this zone. The transition zone is defined as the period from the beginning of ventricular pacing where you have QRS fusion, and including the first beat where you no longer have fusion, the first beat of purely paced morphology. And one criterion, one stipulation here is that you're pacing within 40 milliseconds of the tachycardia. Then you can call that last beat that is of the same pace morphology, you can add that into this transition zone, and you'll see why in a moment. So here's the critical observation. Look at the cycle length of the atrial intervals here as we approach and enter this transition zone during the beginning of pacing. We can see here that the first earliest advanced A is here, where this asterisk is located. And that early A was generated by a fused QRS. What does that mean? It means the same thing as we saw in the previous example. That QRS occurred, that pacing beat occurred while the His bundle was refractory. And therefore, this paced QRS could not possibly have gotten up into the AV node in the retrograde direction because the His bundle had just been activated in the forward direction, as demonstrated by the fact that this QRS is fused. So you couldn't have advanced the A through the retrograde AV node route. Therefore, you have to have an accessory pathway present. That's the only possible way that a fused QRS could have advanced the atrium. That's another subtle difference here compared to the last slide where we talked about tachycardia termination. Here we talked about advancement of the A while the His bundle is refractory. Tells you there must be an accessory pathway there. So let's review the manuscript and what it teaches us. This was published in 2010, and they looked at RV pacing and how it affects atrial timing during this transition zone. The beats that were fused plus the first beat that is no longer fused was included in that transition zone. And look how powerful this observation is if you see an impact on the atrial timing. If the atrium was affected in the transition zone during one of those fused beats or the first non-fused paced beat, then in AVRT cases, ORT cases, 94% of the time you saw an impact on the atrial timing. Either the atrium was advanced, like the example we just saw, or the tachycardia was abruptly terminated, like I showed in the preceding beat example with a single beat. But if you terminate it during this transition zone, during ventricular pacing, that is a powerful observation telling you you are dealing with ORT, AVRT, or even if you delay the atrium, and I'm going to talk about that in the next case in a moment. Compare this and contrast it with AV node reentry of the typical type, AVNRT of the atypical type, or atrial tachycardia, where you would never, in this example where they looked at a lot of cases here, they never saw atrial timing affected when you were pacing in this transition zone. Because the His bundle was refractory, the AV node was not accessible, you couldn't get up to the atrium to terminate an atrial tachycardia either. So a very powerful observation if you see impact on atrial timing during the transition zone of ventricular pacing within 40 milliseconds of the tachycardia cycle length. So back to this example, here we had this fused beat accelerate the A, and so what can we rule out? We can rule out, in this case, atrial tachycardia and AVNRT, because again, this fused beat could not possibly have gotten back up into the AV node or back up to the atrium through that His bundle and AV node route. You could, however, get up through the accessory pathway, which is why the atrium was advanced. So we cross off two things at once during this observation, and we've made the diagnosis. So here's that last scenario where you can see a ventricular paced event, an early ventricular event, actually delaying atrial activity, which I'll go through in detail. Here is a paced PVC beat. You can see again by the pacing artifact in the RV apical catheter and on the surface EKG. And you have SVT ongoing, and it ends up terminating after one beat. And we're going to look at the specific intervals in a moment. But before we do, let's observe the His bundle deflections. And my apologies that they're so small on this example. But you can see with red arrows where the His bundle deflections are before the narrow QRSs. And if you march forward with calipers, you'll see that this pacing stimulus occurs right on time with where you would have expected the next His bundle deflection. And in fact, if you look really closely, I think you may even be able to see the His bundle deflection peeking out from that pacing stimulus. But you don't need to see that to know that this is a His-refractory PVC, because the calipers show you that it's right on time. And actually, there's another reason you know it's His-refractory, because if you compare this paced morphology to other timings of pacing from this exact same site, for example, an earlier paced beat, there's a different morphology between the two. And that's because this is a purely paced QRS morphology from the catheter site, and this is a fused morphology that is a blend between ventricular pacing and the narrow QRS. So the fact that this is a blend, a fused beat, directly implies that the His bundle must have been activated in the forward direction, and not only the His bundle, but the Purkinje fibers as well, because you contributed to the QRS morphology, thereby creating a fused complex. So if we think about the tachycardia mechanisms, which one can easily be ruled out with having impacted the tachycardia with a His-refractory PVC? I'm going to cross off AV and RT because we talked about the back door to the AV node is closed. If the His bundle is refractory, you could not possibly have impacted the AV and RT circuit with a ventricular paced beat if it times with the His bundle. Either you see the His, you use calipers to show that your pacing is on the His, or you see a fused QRS that tells you the His must have been activated in the forward direction. So we're going to cross off AV and RT. But what about atrial tachycardia? Could it be possible that you had the coincidence of an accessory pathway that allowed you to impact the atrium in some way while the His bundle is refractory? Could this in fact be an atrial tachycardia that was terminated with this His-refractory PVC? Well, let's look at the intervals to answer that question. And I alluded to this before. The last atrial event before this tachycardia terminates is delayed. So that would be inconsistent with an atrial tachycardia. If you had an accessory pathway present that was not participating in the tachycardia because it was an ATAC, and you terminated the ATAC with a His-refractory PVC, you should have advanced the A in order to terminate the atrial tachycardia, but here you delayed it. So the fact that you delayed the A and not advanced it also rules out the possibility of an ATAC, even if you had a coincident accessory pathway. It's just not possible. So this single His-refractory PVC that delayed the A, again, makes the diagnosis of AVRT because you ruled out the other two possibilities. And that was that third category in the table that I showed from that transition zone manuscript. And let's just think again how this works in terms of the anatomy. The His bundle is refractory in the forward direction, so therefore paced beat can't possibly get up into the AV node. And so how would it have delayed the A in the AVRT scenario? This early ventricular beat came at a time that the accessory pathway had a relative refractory period occurring. It wasn't absolutely refractory because then you wouldn't have gotten up to the A at all and you would have terminated the tachycardia like a previous example that I showed. But if this PVC occurs and the accessory pathway is in its relative refractory period, then you could get slowed conduction up that accessory pathway and still get to the A, and either the tachycardia may continue or you may have altered the tachycardia circuit just enough that it kind of peters out and actually refractory periods occur the next time round. Maybe you've hit this fast enough that the next time the circuit comes round, the accessory pathway is fully refractory and terminates, which appears to be what occurs here, because you had an A, you got back down to the V, and then you failed to get back up to the A. So the next time round, this was fully refractory and probably caused by that PVC, which altered things just enough to terminate it. So we've covered a lot of material in this 3 hours. And let me just quickly summarize some of the main points that I want you to take away. First and foremost, it's so important to have a system when you do an EP study for SVT. And I went through it in the order that I do it. I look for findings during sinus rhythm. I do baseline pacing maneuvers. I initiate tachycardia. I look for spontaneous observations during tachycardia before I do any maneuvers. And then you can do your maneuvers. I think it's important to always do multiple maneuvers in all SVT cases. It gives you practice to see what the maneuvers accomplish and don't accomplish in each of these cases, and you can learn the pitfalls and the techniques for how to do these maneuvers and interpret them properly. But also, if you do multiple maneuvers and they all point to the same diagnosis, you've validated that diagnosis. Or sometimes you get a conflict, but you should always do a systematic approach and do the same things in every SVT. You will learn, it makes it enjoyable, and you'll be more confident in the diagnosis. It's also important, especially when there's ambiguity and the possibility of coincidence due to a PAC or a PVC, to repeat maneuvers more than once to show that yes, this is an observation I am making because of my maneuver, and this wasn't simply an ectopic beat and a coincidence. I mentioned this, for example, in the Para-Hisian pacing maneuver. I always like to see at least 2 narrower and 2 wider beats, because if you see a change in the VA time, I want to make darn sure that it wasn't just a PAC that came in, that in fact that A is due to the width of the QRS capturing the His or not. So show that the observation is reproducible before you draw a definite conclusion. If you have a conflict, as can happen between different maneuvers or different observations, you need to figure out why that is. You need to think about the exceptions or how you may be misinterpreting an observation, either a spontaneous or one that was done with a maneuver. And ideally you would do that before ablation, because especially if you're burning near the conduction system or in a sensitive place, you certainly do not want to be burning in the wrong spot and cause a complication, especially if you ended up targeting the wrong thing. So figure out the diagnosis before you ablate. And if you're conflicted, you're not sure what's going on, reach out to a colleague, either someone on site, phone a friend, call me. I'm happy to help. And certainly save your case. If for some reason you're stuck and there's no one during the case to call out to, be really thoughtful about whether you should proceed or not. Maybe review the case with somebody else if you think, oh my gosh, I have to burn right next to the His bundle and I'm nervous and I'm not confident about the diagnosis. No one will ever fault you for putting safety first. Always better to live to fight another day, bring the patient back with more information or more insight, and do a complex ablation rather than forge ahead if you're just not sure of what you're doing. We're all continuing to learn, me included, and the more you do this, the better you get. And so I hope that this gives you a strong foundation so that you can start your learning, but recognize so much of your skill set is going to come simply by doing cases, observing cases, go back to the lab after a case is over, even if it's not your own case, and go through it methodically and learn from other people's cases or your own cases. I always learn new things when I go back afterward and look at all the electrograms from a case. It's just too much information to process real time. Take your time and go back over it after the fact. Every single time, I guarantee you, you're going to find some interesting observations and learn more in hindsight than you actually realized during the case itself. I really hope that this was helpful for you, and thank you so much for your patience and attention during such a long presentation. I wanted to be comprehensive and make sure that I gave you a strong foundation in your career of diagnosing SVT in the EP lab. Oh, what's this? Oh, I almost forgot. I'm ending with an A. Wink.